Good morning, everyone. Welcome.
Morning.
Hey, good morning, Kasey. Good morning, Suzanne.
Hello, Bill.
Steve Barnes just got off a ICS call, and he's going to be joining me in just a second. So,
Hey.
I like the music. Is that my background music, or did I have any?
I'm hearing it too.
Oh, at least it's not the elevator music. So.
Yeah, and we got Greg that's joined the line as well, and then Bryan should be joining here in a few minutes.
Great.
Do we need to drive our own PowerPoint slide, or are you guys driving? What's the plan for that?
Is that to you, me? That to me, Kasey?
Katie and Susie.
Oh, Katie and Susie. Okay.
It's up to you. I'm happy to share it.
Okay. I mean, I can maneuver the slides if you want to give me the ability to share screen.
Sure thing. I think you might already have it. Let's see.
Okay. It says I can't share while others are sharing.
Oh, okay.
So I should be able to share, it looks like.
Yeah. Once we start there, we'll start sharing and then.
Okay.
Yeah, then Katie will just keep them up as a backup in case, of course, we have any weird technological malfunctions through this. But welcome and happy to meet you in this very form. Someday we'll meet in person, Bill, and other people, and Greg, but I'm happy to meet everybody via Zoom this morning. And thank you so much for joining us today. And thanks, Kasey, for your all your facilitation work.
Yeah.
Really appreciate it.
No problem.
Kasey's been a great partner for us in the short period of time that we've worked with him. So.
Appreciate that, Bill. It looks like Bryan's joined as well. So all of our speakers are here. So we're good to go.
Great. Just Katie and I are going to do just a very brief introduction for the day, and then Claire probably has a little bit of housekeeping information, and we will turn the stage over. So that's how we're rolling this morning.
Steve Barnes should be joining. Are you on, Steve? He's just right across from me here, so he should be joining us in just a second. So.
Okay.
Steve is saying that he needs to be accepted in. He's someone who's the keeper of the key, holder of the key for. You see him? You see him? Okay. You don't have to let him in, Katie, if you don't want. It's okay. He's in. Okay.
Okay, I'm here. Thanks for making me a presenter.
And then Bryan and Greg and Bill and Steve, we have 55 minutes. I'm planning on only taking 5 to 7 minutes on my end to preserve somewhere between 20 and 25 minutes for each of your groups. So, and it goes to Greg after me, and then Bryan, they're kind of co-presenting together. So I think that it was going to go to Bryan or to Greg to talk a little bit about the Castleview side of things and why they wanted to work with Bryan on their center, and then Bryan to explain what that process looked like, and then it skips over to Bill and Steve after that to finish out with your work. So just a heads up on what that's going to look like, just a reminder. So, and thank you to all 4 of you for taking time to join and being willing to present with us this morning. I really appreciate it.
Yeah, Casey, this is Bryan. Jensen here. How are you doing today?
Yeah, doing great. How are you doing? It's good to see a face instead of just a phone call.
Right?
Yeah.
Yeah. Our presentation, I don't know that it's going to take 25 minutes. Hopefully that's okay. We'll try to keep it or stretch it as long as we can.
Okay. Bill, yours can take any range of time, right? You guys can clean up if there's a little bit more than 25 minutes for you.
We'll be the pinch hitters and or the closing pitchers if you need us to be.
That works. And then I'm sure probably wouldn't hurt if we're 5 minutes early letting out, right, Katie?
Yeah, actually the session ends at 9:50.
Oh, so it's only 45 minutes.
Yes.
All right, so we should be good then. You guys don't no pressure to take 25 minutes, Bryan, more like 15 to 20.
Perfect.
Okay. I like shorter. Shorter's good.
And our audience has been pretty good about giving us quite a few questions in the chat and the Q&A. So I'm hoping that continues.
Mm-hmm.
So that will be good as well.
Excellent. Okay.
Hey, Kasey, unless you need us on, we're just going to mute and turn our video off.
Yeah, you're good. If you're just hang out and be ready to go, and we're ready to pass over to you.
Yeah, we're here.
And then for all of our presenters, I'll just let me know. Just say next slide, and I'll scroll through the presentation slides for you. I'll have control of that.
Welcome everybody to our summit today. I am Susie Prevedel with USU Extension in the Tribal and Opioid Resource Center located in the Roosevelt Extension office in Duchesne County, Northeastern Utah. So I'd love to have everybody joining us today and was so excited for what happened yesterday. So I am going to turn the time to Katie Zaman, who is our program coordinator for our rural opioid technical assistance grant through SAMHSA and bringing you this summit this week. So welcome.
Thanks, Susie. Good morning, everyone. Welcome back to all of you who enjoyed yesterday with us, and to our new participants. We're really happy to have you here with us today. On behalf of the Tribal and Rural Opioid Initiative and Utah State University's Office of Health Equity and Community Engagement, welcome to day 2 of the 2021 Intermountain Tribal and Rural Opioid Wellness Summit. We're proud to present you with more amazing educators, industry experts, local healthcare and community leaders, and presenters who will offer more of the most current and pertinent topics surrounding stigma and harm reduction, and surrounding substance abuse and opioid use disorder. We're going to go over some concepts that are proven to help create recovery-ready communities. This morning, we're welcoming 5 guests representing the Rural Health Association of Utah, who will discuss building a recovery-ready community. This year's summit is sponsored by the Utah Department of Human Services, the Rural Health Association of Utah, Utah State University, USU Emma Eccles Jones College of Education and Human Services, Department of Kinesiology and Health Sciences, the USU College of Humanities and Social Sciences, USU Extension, and SAMHSA. I'm going to hand it over to Claire briefly to go over some housekeeping.
Awesome. Thanks, Katie. Good morning, everybody. Welcome back. We're excited to have you back today. So today's session schedule are going to be pretty similar to yesterday's. We're going to have our keynote sessions this morning, and then we will have separate breakout sessions for the lunchtime activities and for the afternoon. So we will be putting those links in the chat box again as we get towards the end of the morning sessions, but remember to check your email reminders, which will have the whole day's schedule and links on there as well, if you would like to have that open and ready. This is just a quick reminder that we are recording our sessions, which includes recording the chat box and the Q&A questions. So if you would like to remain anonymous, please make sure you check the submit anonymous button on the Q&A questions. Another reminder that our morning sessions, we are going to be using the Zoom webinar feature, which means that attendees will not be able to turn on their videos or microphones at certain times. If presenters have times for verbal Q&A, please just click the raise hand button and we will make sure to unmute your microphone for you to ask those questions. And then a quick reminder to also, when you are responding to questions in the chat box, if you would like everyone to see the response, like if we're doing a general question to everybody, please make sure you select send to panelists and attendees in the drop-down file. I think yesterday we got a lot of responses just go to the panelists instead of to everybody. So just keep an eye on that when you're submitting your questions. The peer support room will be open again today from 10 a.m. to 1 p.m. So once that's opened up, we will put the link to that in the chat box as well. And if at any time you have questions about any of that, feel free to send a question through the Q&A or to the panelists in the chat. We did have a couple questions yesterday about CEU documentation, requesting that. We will be sending out a request form for CEU documentation at the end of the summit. So keep an eye out for those reminder emails at the end. And then to get us started this morning, we've got a couple really quick, fun poll questions I'll just put up there really fast. So just take a second to answer those and I will turn that back over to you, Katie.
Thanks so much, Claire. Now I'd like to introduce our keynote speakers for today. Kasey DeLynn Shakespear, Senior Program Manager from the Utah Rural Health Center and Southern Utah University. Bryan Jensen, CEO of StepOne Service. Greg Cook, CEO of Castleview Hospital in Price, Utah. Bill Newell of the Opioid Response Strategy. And Stephen Barnes, I don't have your title or affiliation, but I'm sure that we'll hear that coming up here. So Kasey DeLynn Shakespear is a senior program manager with the Utah Center for Rural Health at Southern Utah University, where he's worked for the past 4.5 years. He received separate master's degrees in healthcare administration and public health from the University of Utah, and a master's degree in English creative writing from Southern New Hampshire University. Kasey grew up in Tropic, Utah, near Bryce Canyon National Park. He has carried a passion for rural health with him as he has moved into his career in healthcare and continues to be an advocate for improving access and resources to rural communities throughout Utah. I'll hand it over to you, Kasey. Thank you so much for being here today.
Thank you, Katie. I appreciate it. Thank you for the introduction. So, like Katie said, I'm with the Utah Center for Rural Health. It's housed at Southern Utah University, and my role there is to help manage our communities projects, our grants, and our Rural Health Association of Utah. So, a couple things with that role that's led me to work with opioids. Specifically, slides to progress. There we go. So, I am the program director for our Utah Rural Opioid Healthcare Consortium, which is a group that makes up about 9 counties in Utah. So we serve Beaver, Carbon, Emery, Grand, Garfield, Iron, Kane, Paiute, and Wayne County. So we serve these counties under 2 different rural communities opioid response program grants, but it's all part of one big happy family in the UROC consortium. And what we do with UROC is we try to bring together all of these entities, the FQHCs, public health and behavioral health departments, local providers, nonprofit organizations, in an effort to coordinate resources and expertise in order to combat opioid issues in those counties. We've been active as a consortium since 2018, and we've just added grants and counties and consortium members along the way. Greg and his team, his hospital has been a part of our consortium for a couple of years now. And Bill and Steve have just recently joined, and then we're working on some projects to hopefully be able to work more closely with Bryan and his group out in Carbon as well. And we're funded through the Rural Communities Opioid Response Program grants through HRSA. Just wanted to highlight a few of the activities that we've been doing as coalition in those counties. We've hosted a few events, one in Beaver and one in Carbon County. And we're looking at hosting a few more events in the upcoming year. So hopefully if you're in those counties, you'll be hearing from us. We're also working on planning a law enforcement first responder summit to service those areas as well this October. We've been working on doing things like preparing trainings for youth on refusal skills. We've run a few educational incentive programs. You may have participated in those. We've done incentive payment programs to help providers get MAT waivered, as well as some general Project ECHO trainings. And those are ongoing. So if you're in one of those counties, feel free to reach out to me about those programs. We also manage social media and websites. We are the owners of the UtahOpioids.org website, and we're working on building out that as a further resource for those communities. And then we do things like support drug take-back activities. We've distributed Deterra kits and other drug take-back items and participated in some of those events. So we've tried to stay quite active. It's been a challenge through, as many of you probably could say the same thing. COVID has been a real challenge to keep a lot of these activities rolling, but we fought through that and kept going as a coalition and consortium. And we're excited to be able to move into hopefully the post-COVID world where we can start getting more in depth into some of these activities. But and then specifically in Garfield, Kane, Paiute, and Wayne County, we also work closely with a partner called Aspire 365. And Aspire 365 is an at-home treatment recovery group, and they do recovery services for, it's not just opioids, but all substance use issues. And what's unique about Aspire 365 is they treat chronic illness they treat substance use as a chronic illness rather than an acute illness. So your traditional treatment model is, a 30 to 90 day inpatient service, and this is a full 365-day program with a 5-year follow-up. And it's all done via telehealth. So it helps with, for those that are in remote communities that can't travel out of the community to get treatment, or, to help them stay at work and with their families rather than having to uproot their lives for that traditional 30 to 90 day period. This is an alternative to that. They are licensed to treat throughout Utah, but specifically for individuals residing in Garfield, Kane, Paiute, and Wayne County, we have our second implementation grant through RCorp that helps cover the cost of that service. So if you're working with anybody in those counties who could benefit from a service like this, definitely reach out to us as well. We're covering anywhere from 90 to 100% of that cost for about 18 individuals over the next couple of years. So I'd love to connect with anybody in those counties that have questions. And then I just also wanted to put in a little plug as well that our Rural Health Association is planning our upcoming conference this November. It'll be housed at Dixie State University. We're planning November 12th, still working on confirming that date. And we are planning on also having a pre-conference golf tournament at Bloomington Country Club here in St. George as well. So if you want to come down and enjoy some good weather and learn a little bit more about rural health issues, watch out. We'll be sending some save the dates out for that once we get that confirmed. Look forward to seeing as many people as are available to come down to that conference. So that's all I've got for our Rural Health Association and our UROC activities. I'd like to pass the time over now to Greg Cook to talk a little bit about the work he's doing with Bryan Jensen there in Price.
Yeah, thank you and good morning. I appreciate the opportunity. I'm going to take just a couple minutes and introduce myself and introduce the hospital. And then I'll turn the time over to Bryan Jensen, who is the co-founder and CEO of Evergreen Healthcare Partners, who helped us get going with StepOne services. So my name is Greg Cook. I'm the CEO here. I've been at this hospital for going on 8 years. So I've lived in the Carbon County area for a fair amount of time. Grew up in Utah, grew up in Vernal actually, so I'm familiar with small towns in Utah. And I was excited to have the opportunity to work close to home, and Price has been a good place to do that. So our hospital is a typical rural community hospital, but we do have a lot of wonderful quality indicators. And so when we do something, we always want to make sure we do it well. We're always looking for opportunities to help the community, and we try to give back where we can. When we started discussing detox services, again, we're not a behavioral health hospital. We don't do any behavioral health, but we do take patients that are sick and help them get better, and we send them home. We watched a presentation. I can't remember if it was a presentation by the Utah Hospital Association or if it was through the Utah Hospital Association, but there was one slide that stuck out to me. It was a map of Utah by county that was color-coded, showing the kind of a substance abuse numbers. And Carbon County was a black eye. I think we had the darkest color in the state, and that was very concerning. Addiction has touched my family closely, and so we started talking about what we could do to help. And again, if we can't do something well, we don't want to do it. So we looked at the medical management side of addiction, and it was important to me that if we start a program, that we not just take patients in, manage their withdrawal symptoms, and send them home. That's not a successful solution. Those patients are going to relapse, and we just end up as a revolving door. So we had patients, that would come to the emergency department for various reasons. We would admit them to the ICU and manage their withdrawal symptoms and send them home, and it just doesn't work. So we engaged Bryan, and he'll speak to you a little bit about the program and what they do. We engaged them with the expectation that we can't have a revolving door. We've got to be able to treat these patients, manage their withdrawal symptoms, and then try to facilitate their entry into a treatment program, so that we can get these patients healthier and really help our community kind of pull out of this dark hole that we've been in. So we engaged them. Wonderful company, wonderful program. It's been very successful. We started back in, I believe, November, and volumes continue to grow. The number of patients that we're able to help continues to increase. May this month has been our biggest month ever, and so we've successfully treated patients, managed their withdrawal symptoms, and helped them find some treatment after the fact. The success rates have been high. Satisfaction rates have been high, and compliance rates have been high, and that pleases me in opening a program that we can help the community. So I'm very pleased with what Evergreen has done. Bryan will tell a little bit about the program, and you're certainly welcome to reach out to me if you've got any questions about that. But I feel like Carbon County is starting to turn around, and we hear the success stories and the feedback from the patients all the time. The individual that we've got in this role, in the coordinator role here, is just absolutely fantastic. Her name is Suzanne Ely. She's probably on the conference right now, but she's doing a fantastic job. She relates well with the patients. She follows them through the process. So once they've been discharged and she's found a home for them for further treatment, she calls them on almost a daily basis. And the patients truly know that she cares, and I think that's a key portion of the success to our program as well. So with that, that's kind of an overview of how we got to where we are. I'm very pleased with the way things are going, and I think we'll just continue to be able to help patients. So Bryan, I'm going to turn the time over to you.
Okay. Thanks, Greg. I certainly appreciate you providing that overview and introduction, because as you and I both know, this is something that we worked hard to bring together and get it off the ground at Castleview. And without your dedication and folks to make sure that happened, we wouldn't be here. We wouldn't be making a difference. So truly am thankful for the dedication you've given to this service. And I know Savannah is on this call, and she, to Greg's point, is really just an outstanding individual that within a few minutes of talking with her when we were recruiting for the local position to be on set at the hospital, knew that she was absolutely the perfect fit for the culture of our organization, that has compassion, dedication, just through and through, an outstanding individual that anybody that approaches the service can have full confidence that they're going to be in the right hands. I think that is really important. So for the presentation today, really kind of have it in two pieces. One is just to talk about the service on a high level, what it is, how somebody accesses it, the process they go through, and then on the back end of that, not necessarily in any level of importance, but talk a little bit about how the hospital partnership works and the process somebody would go through if there are other hospitals out there that are interested in a service of this nature. So go ahead and go to the next slide there. So what is it? This is a unique service in the fact that it's not often what you find in the hospital setting. It's something that typically takes conversation or discussion to understand the uniqueness of it, because it really is a kind of a niche approach to providing an element of substance use disorder treatment. So the service itself is a short-term, hospital-based, blended right into a med-surg unit, not a designated unit, not a psych unit, anything of that nature. It's 3 to 5 days. The patient's in the hospital for essentially withdrawal management from alcohol and or opioids. It's a voluntary admission. This is something that, again, it's not a psych unit. It's for the individual truly this is the appropriate venue for them. They're going to meet the medical necessity criteria and they're ready to come in. Ready being something I'll talk about in a minute here. It gives them a safe environment, around the clock medical care by trained clinicians, both from the hospitalist team and the nursing team, that really understand the best way to go about treating these individuals in a dignified manner that's going to give them the type of care they deserve. They have medication protocols specific to the substances so that they can stay ahead of the withdrawal and make it as comfortable as possible for the individuals going through the service. Okay. Who we treat. This is for adults only. It's for somebody, as I mentioned a minute ago, that's going to meet medical necessity criteria to come into the hospital and really warrant that level of care. They need to be somebody who is sick enough, essentially, to really need the intense setting of a hospital and the resources that can be brought to that individual. And the other part of it is we're always looking for individuals that are motivated to make a change. We don't want this to be a revolving door. This is set up really for an individual that is ready to begin their journey towards recovery. So it's from door to door. They've got to be willing and able to work within a med-surg environment, be compliant in that setting, be respectful of the team there, because they're providing the clinical care somebody needs, and it really needs to be somebody that understands this is a med-surg unit. They need to go into a med-surg bed and behave like any other medical patient. And then, like I said, be ready to go on to the next level of care and continue their journey towards recovery. So it may be, timing for the individual as much as anything that they present in an appropriate time in their journey to really make a difference or make a change in their life. Okay. So the process by which somebody will access the service, and it's really key that they don't just show up at the hospital. We really message that somebody needs to come in via telephone conversation with Savannah on the front end. And it often, the reason we say that, it may be the first conversation when they're ready to come in, but a lot of times it ends up being the third or fifth or 10th conversation before they're really ready to come in to the service, and it's the right, you know, situation, circumstances for them. And that telephone pre-screening is to assess, to make sure that, you know, this is, you know, potentially the right starting point for somebody, because they have to meet medical necessity criteria. If they need more of a structured environment, we'll help them find that. If they need a less intensive environment or venue, we'll help them find that as well. So we don't want them making an unnecessary trip to the hospital. If they appear to be ready, they come in for a face-to-face assessment by Savannah at the hospital. That is done, you know, on campus. And at the conclusion of that, they present, or Savannah will present, they present that to the admitting team and the physician covering the service at that point, to make sure that they agree that the patient is appropriate, or the individual is appropriate to be a patient. If so, they get admitted like any other medical patient, and we walk them through that process. It's, you know, the key thing is patient engagement. And then while they're there, once they're in bed, we immediately start talking about that discharge plan of where do they go next, because they're only in the hospital for 3 to 5 days. So we need to be very proactive with that and start planning immediately to find out what's going to be the best plan once they're ready for discharge. Is it residential? Is it outpatient? Do they want medically assisted treatment to be blended into their plan? It's really, you know, doing a lot of education around what's out there. Unfortunately, as we find, not just in this market, but any market where we're located across the country, it's trying to navigate the continuum of care is challenging for an individual. And anything we can do to help educate them around what's out there, how they work, you know, what typically is a good course of treatment. That's something that we really have to do, and I can't sing Savannah's praise enough here. She does an outstanding job with that. And then, as Greg touched upon earlier, once they're discharged, we have a structured up to 6 months post-discharge, you know, engagement that we follow with each patient to make sure that we're there as a resource. But Greg touched on, Savannah talks with a lot of these individuals on a daily basis. She goes above and beyond. But we feel like that's a really important element, so that they know they can turn to the service at any point should the first option not work out, should they have additional questions, or should something have changed in their life where they may have to go a different direction. So it's just knowing that they're going to have that ongoing engagement, so they have somebody they can turn to. Okay, next one. So just kind of wrapping up, and again, we're trying to be efficient with everyone's time here, but if everything we do, and not to you know, diminish the excellent quality care that's delivered at Castleview, and all the professionals that are dedicated to really treating these patients with dignity and respect, that patient engagement and care coordination that the service offers really is a difference maker. It's from door to door, and I think that allows somebody to understand they're in good hands, and they've you know, turned to the right option to begin their journey. So I think that's something that we really pride ourselves on, and a lot of the positive feedback we get from the surveys is that it was the way that they were handled once they came to the hospital that really makes a difference. And I think that reflects well on everyone involved at the hospital, from the physicians, from the nurses, from dietary, you know, you name it, anybody that's touching or involved in this case or these cases, they really are there to make a difference, and the quality is outstanding. Okay. So as far as new hospital partnerships and how that works, we, as a company, what we have put together is a turnkey partnership model that really is all encompassing for a hospital that's looking to get into this type of treatment. And, you know, that includes an implementation that covers all elements that need to be, you know, established before going live. We modify that so that it really works well at each hospital, recognizing that every hospital is a little unique, and what works at one site may not work so well at another. So we have to adapt it to where it really blends in and accounts for any unique nuances. do clinical education. That is making sure that everyone's on the same page with regard to how we approach and treat these individuals that need help. That includes, sample medical protocols that are submitted, specific to substances, training and education of the nursing team, case management, you name it, all the departments that roll or are involved in navigating these patients through the hospital in an efficient and effective manner. They're incorporated in that planning. So that kind of ties into the systems. And then beyond that, kind of behind the scenes, we do a lot from a community awareness perspective to make sure that the information is pushed out to the individuals that are in need, or somebody that may hear about the service and know somebody that needs help. We want to always make sure that this is something that becomes visible to the community as another level of resource and as a complement to what's already in place throughout the continuum of care. Quality assurance, Greg touched upon that earlier. That's always, really high on our radar for the fact that we got to make sure that we're doing this the right way and we're providing the quality type of service that the individuals in need deserve, the community, the region that deserve, quality resources. So we have a variety of quality metrics to build in and monitor throughout the operation of the service. And then going back to the dedicated patient engagement care coordination, that's hiring the right talent to fill the roles and making sure they have the resources and tools that they need in order to do their job on a daily basis. Okay. And then just going through the typical process, for a hospital that may be interested in a service like this, we do a few things because it's really important that we understand the market. So we have to work closely with hospital leadership and other resources in and around the community to make sure that we are looking at this service and considering it for a market for the right reasons. So it begins with an assessment of bed need, and that can differ from one market to another. We just opened a site in Atlanta, Georgia. Well, that's typically going to serve patients within a 50-mile radius, where a location like Castleview, obviously a much greater radius. Individuals will travel for quality care is what we find, but we want to typically look at what's going on to find out, what that need is and how many beds a hospital is going to need to be able to commit to the service to make sure the patients can access it in a reasonable amount of time. Then we look at evaluation of area and regional resources as it relates to substance use disorder treatment, because there has to be that collaborative effort of other resources that can handle the individual treatment of the underlying disease once they've been medically stabilized and they're ready to move on to the next level of care. Unfortunately, we've had a number of hospitals that have come to us over the years asking for a service like this, but there just weren't enough resources around, unfortunately, to be able to handle the patients, upon discharge in a reasonable amount of time. And if you don't have resources out there, you're not doing the right thing for anyone involved. It truly has to be a hand-in-hand relationship with the treatment community to offer this service. Then we do a financial analysis, and then ultimately a formal proposal that is presented to the hospital that includes really every element of the service, how it works, how it flows, the partnership structure, you name it, to make sure that everyone is on the same page, on board, and understands their involvement that would be required in order to offer a service like this in a way that we feel like it needs to be done. So I know I'm kind of cruising through here, and there may be some questions. Happy to answer them as we move along or after the fact. And I think the next page here will allow us to show where that information can be sent. So to contact Savannah at the hospital, there is a telephone number here on the right top portion of the page, or there's a QR code that can be scanned, and it allows somebody to read more about the service, probably cover the job in a better way than I did today in this presentation. But it also allows for them to for anyone to submit a pre-screening request, which would go directly to the email account for Savannah, and she can respond to that and coordinate a time to connect via telephone. And then for questions related to the service itself and Evergreen Healthcare Partners, we're the parent company behind StepOne service. My contact information is here on the top left or the left portion of the page, and happy to take calls, answer emails, or do whatever it takes to make sure that if I haven't covered any particular points or there's questions around them, happy to do that. So I think that's it for today, but I appreciate everyone's time. I appreciate the opportunity to participate in your event, and really grateful for everything that y'all are doing for those in need.
Hey, good morning, everybody. We're going to transition into the partnership that myself and Steve Barnes are a part of, which is the overdose response strategy. And as part of that, actually segue greatly, I think, based on what I just heard regarding the StepOne model, into some of the initiatives that we are promoting, supporting, advocating for within the state of Utah. So a quick, if you can go to the next slide, please. So just quickly, in 2015, the Office of National Drug Control Policy, also known as the Drug Czar, partnered with the CDC to form what was called then the heroin response strategy. It is currently known as after a couple of years of some changes in nomenclature, it's now known as the overdose response strategy. And the idea is, with ONDCP being primarily public safety, law enforcement, to partner with the CDC, obviously public health, with teams in each of the 50 states. Currently, about half the states in the United States have these teams, and the teams are comprised of a drug intelligence officer, such as myself, Bill Newell, who are senior law enforcement, normally recently retired, within that state, and have the ability to make contacts with individuals who, at all levels, federal, state, local, tribal, law enforcement, and advocate for cooperation with and collaborative efforts with public health. And then I'll let Steve introduce himself.
Yeah, thanks, Bill. So like Bill said, my name is Steve Barnes, and I'm the public health analyst in the Utah State team here with the ORS. And I'm assigned to the Utah Department of Health. But as Bill described with that program, the emphasis is really surrounding collaboration between public health and law enforcement. So yeah, we can probably go to the next slide.
So the overdose response strategy, briefly, and it again, it's not supposed to be overly complicated. And this is really this is directly out of the overdose response strategy website, which you can find under ors.gov or ORS HIDA. And it's really three parts. It's to collaborate across public health and public safety sectors. It is well known, I think many of us know, that public health and public safety sometimes speak different languages. And so sorry about that background noise. Something just went off here at DPS headquarters. Sorry about that. So collaborate across public health and public safety sectors to share data, insights, and trends that we're seeing, as like we've talked about, obviously StepOne being a great example, and then inform and help local communities develop local solutions. We are part of a national network of teams, public health analysts and drug intelligence officers who are, for instance, Steve Barnes, an epidemiologist. So most of the public health analysts are epidemiologists. And so whenever there's something in another state that we think might work here or might be of interest here, sorry about that background noise. I'm not sure what just happened, but something just happened here at DPS headquarters. And so whenever we hear of something that it may be of interest or we might think might work here within the state of Utah, that we might hear from another state partner team in, let's say, Georgia or wherever, we work with our partners within the state of Utah and say, hey, this is something that another state is working on, and we might think might be of interest. And we're actually going to talk about something that's happening within the state of Utah that we think might be of interest to this audience. Next slide, please. Steve, you want to cover these really quick?
Yeah, sure. So just at a high level, some of the ORS program goals, they surround things like data sharing. again, between public health and law enforcement, trying to improve the timeliness of data sharing, supporting evidence-based responses. And, a lot of that is related to what Bill said of, just trying to identify what's working, where there's evidence for these programs that might be implemented elsewhere, and then seeing how we might be able to bring those to Utah. The third one is, designing and using promising strategies that might not necessarily meet the level of an evidence-based response, but promising strategy, especially at the intersection of public health and public safety. If you go to the next, the last one is looking at effective and efficient primary prevention strategies, which is one of the things that we are always trying to work towards, the upstream approaches. Next slide. So just to kind of highlight some of the efforts that we work on and support. One of the things that I've been doing a lot with the Department of Health is strengthening the overdose response when a cluster or a abnormal spike in overdoses happens. So we do this through, or Bill and I support this through, working on partnerships with, for example, the DPS Forensic Laboratory. They offer one of the only data sources that gives us information and intelligence about the drugs that are currently, circulating within the community. Also enhancing the data from the medical examiner, in particular the timeliness of it, so that it can be more useful to us at the state and also at the local level, being able to use that data to actually respond and hopefully prevent further issues and overdoses. Also, we know that a lot of the data systems that we use aren't perfect and aren't complete. So we've been working with Salt Lake City Fire Department. They have a kind of a community outreach program, and also other just community partners to get even just anecdotal accounts of what they're seeing, and then using that to bring that back to the health department leadership to determine if a larger response is necessary or other areas where we should be looking. Also, developing different tools for the health department and even DPS to use to monitor emerging drug trends. Like one of the ones that we've been looking at, for example, is developing better tools to monitor methamphetamine and benzodiazepine or illicit benzodiazepine use overdoses in the community, especially related to counterfeit pills that may be sold as different things than what they actually are. Yeah, and this is all just related to that first goal that I was previously talking about data sharing. Next slide. So one of the things that we really want to talk about today is the work that Bill and I have been doing to support the receiving center. This is a model that has been implemented in Davis County. It's a really promising practice, and we're currently working with Nicole Kuna at the state level to do what we can to support the expansion and of new receiving centers beyond just Davis County. And one of the key components of the receiving center is law enforcement buy-in and participation. So that's one of the areas where Bill has been tremendously helpful, just because of his entire career before all of this. Bringing those partners to the table to start the discussion, and there's been overwhelming support for it. But basically, we'll get into this, but in a nutshell, the receiving center kind of acts like a hub where people who are experiencing an acute mental health or substance use disorder related crisis anyone in the community can bring somebody there. Law enforcement can also bring someone there in lieu of incarceration, which is really helpful for diverting people into treatment instead of jail. But we'll get into that more. One of the things that Bill and I have really been trying to do what we can to support is to bring a receiving center type model to communities in rural Utah, because the need is there, and a lot of times these things, resources are concentrated and focused in the main population center, Salt Lake area. So really trying to address the need in rural Utah. Next slide. One last thing, another example of the types of work we do. One of the partners that we work with a lot is the Utah National Guard. They have a civil operations drug demand reduction program. So we like to bring them in and get them at the table. They're a great partner to work with, and they can help support the implementation of evidence-based prevention programming. They're really focused right now on just building their coalitions. A lot of it's surrounding youth and substance use disorder and upstream prevention, which is really great to see them throwing a lot of resources at that. Next slide. So this is a list of a lot of the partners that we work with, just to kind of give an example of the scope of what we do. And we really we're open to and always looking for new partners to work with. Really anyone who's working in the space of substance use disorder and overdose. We like to build relationships there, and so we can understand how we might be able to use our connections and the ORS and bring additional resources, be it partnerships or data sharing, anything like that, to further all of the work that you all are doing. And Bill, I don't know, is there anything else you want to say about the partners or anything on the slide?
No, I just wanted to, I think it's a great cross. You can see it's a great cross section of different public health and public safety entities within the state of Utah. We're very lucky. We have great partnerships and great relationships across both sectors. Summits such as this are great because it just brings more information out to individuals who might not be aware of this. And so if anybody has any information or any requests for additional information about what we do or how we can work with you, our information will be obviously part of this, and please feel free to reach out. So we'll go to the next slide, please. So this is with Nicole Cunha's permission. I took several slides from her presentation. She was not able to join us today. She's on leave, much deserved leave. So the receiving center concept briefly, and I know we only have a few minutes. So briefly what it was, it's really a perfect example of how public safety and public health can work together to address a common issue. Tom Ross was the chief of the quick background on the Davis County Receiving Center. So Tom Ross was the chief of Bountiful Police Department for many, many years, and is now currently the executive director of CCJJ, which is, those of you who are familiar with that, is the Commission on Criminal and Juvenile Justice, a cabinet level, works for Governor Cox. And Tom Ross is a tremendous advocate and proponent of this model. And so for several years, his officers, and this is common across the United States, law enforcement gets a bad reputation in this respect, but I think you will find many, many law enforcement professionals, such as myself, and of course Tom Ross, stating we have to find an additional method in lieu of incarceration to divert people that are suffering from acute mental health or substance abuse disorders. And so what Davis and Tom Ross, working with Nicole Cunha, who at the time was with Davis County Behavioral Health, for many years worked together with a partner across all the partners, public and private partners, and within the Davis County, and came up with what basically is the receiving center. And I'll just cover this briefly again. We only have a minute or so. So basically, law enforcement has been and continues to be across the country the go-to first stop for anybody dealing with individuals who are dealing with substance abuse and or mental health, so-called criminal activity, if you will. People that are hanging out in parks, people that are shoplifting to fund their drug habits, whatever it might be. So they came up with a receiving center, which is basically a one-stop shop for where officers and in the public, but currently about half the individuals referred to the Davis County Receiving Center are from law enforcement, to address several problems that have come up across the country. And this is over-reliance on law enforcement for mental health and substance abuse, the misunderstanding, misinterpretation, and maladaptive outcomes of law enforcement. We're not trained. I was a law enforcement professional for 32 years. We're not trained to deal with substance abuse and mental health issues. I mean, we receive basic training, but we're not public health officials, professionals such as many of you on this webinar. And again, it's excessive wait times in emergency departments for both patients and law enforcement. Officers many times will spend an hour and a half in a hospital trying to get someone stabilized or in jail for the same reason. Whereas the receiving center, and this is the great selling point for law enforcement, the receiving center, as it was set up in Davis County, is about a 6 to 7 minute turnaround time for officers that are given the authorization from the police department and with the receiving center's approval to take the individuals there and drop them off, and they're received by the receiving center staff. And so let's go to the next slide, please. I think we only have a couple of minutes, so I'm going to try to make this quick. So the cost of the consumer in society, and this is where, you know, if someone goes to jail or someone goes to the hospital, and the whole point of the receiving center, and Tom Ross is a great advocate, is in law enforcement, many chiefs that I know and personally know across the country, and sheriffs and other federal agencies as well, will say, we need to have another place to take these individuals. They don't belong in jail. Jail is not where these individuals are going to get the help they need. And they have to meet a certain criteria. It has to be misdemeanors, non-restitution type crimes. If they're felonies or if they involve some sort of violence or restitution, they don't qualify, at least for the Davis County Receiving Center model. So these are the low-level offenders that are in need of jail, are in need of acute substance use or mental health treatment by professionals, not to be found in jails. And so you can read this yourself, but basically the idea is to find an alternative way to get these individuals to treatment that they will not otherwise find. Next slide, please. The solution, the basic idea that they came up with the Davis County Receiving Center, that went into effect in December of 2019. And so far, the results have been very, very promising. And again, I'm covering this very quickly. I apologize. If anybody wants additional information on the Receiving Center, please reach out to me and I can put you in touch with Nicole Kuna. So it's community-based diversion. It's a zero refusal and harm reduction-based policy. Zero refusal meaning if they meet the criteria that is jointly agreed upon by the receiving center, in this case Davis County, by both public health and public safety, there's a zero refusal for anybody, public and or law enforcement. And it's really about a 24-hour turnaround time. It's a hub for additional treatments, additional resources, and they stabilize them and then they find them additional places to go. Next slide, please. And so what it is it's a pre-booking diversion. And so what it is these individuals, who many of these individuals, and I can tell you from law enforcement, many of these individuals have long so-called rap sheets of misdemeanor crimes, shoplifting, larceny, loitering, but they're not criminals per se. They're just people that need help. And so what this pre-booking diversion program is the officer responds. Let's say the officer gets a call regarding some individuals hanging out in a park that are, you know, using illicit substances. The officer will respond if it meets the criteria of the crime, being a misdemeanor, non-restitution, non-violent, which many of these are. The officer calls his or her department and says, hey, I have an individual who, and of course the individuals, and the great thing about this, the word has gone out among the user community about the receiving center. The great Tom Ross will tell you, one of the greatest things about this, he goes, Bill, is these individuals are calling the police department saying, I need to go here, or I have someone who I needs to go to the receiving center. He says, that's what we want. We want these individuals to find this as a resource for them and not be some sort of criminal type Stigma. So the officer, and going back to the example, the officer will call his dispatch or her dispatch and say, hey, we have an individual who meets this criteria. The individual agrees to go. The police department will call the receiving center and say, hey, we have an individual, officer so-and-so is bringing this individual. The turnaround time again is 6 to 7 minutes. The officer transports that individual to receiving center, is received. The report that is written about that incident is held in abeyance. If the individual meets a certain benchmarks for treatment as established by the receiving center, that and if they the individual that's being referred satisfactorily meets those benchmarks, the reports are never filed. The courts are on board, the police department's on board, all the public health and public entities are public safety entities are on board. So that individual never gets charged with this offense that led them to getting to the receiving center, because that's not really what law enforcement wants to do. They want to get them help. And so it's a great, and so to date, as of December of 19, of the 500 or so individuals referred to the receiving center, not all by law enforcement, about half, about 78% have met the 60-day benchmark for treatment. 60 days being what the Davis County Receiving Center has said, if they meet 60 days of treatment, benchmarks for treatment, they are on the path to recovery. And so 78% of those individuals have met that benchmark, which means those individuals never be formally charged with a crime. Next slide, please. And so this just, okay, I'm sorry, I think we're done. Sorry. And we can go, let's skip to the next few slides. Yeah. And then again, I'm sorry, there's a lot to go there, but if you have any additional information, please reach out to me or Steve Barnes and we can get you that information.
Thank you so much. I didn't mean to cut you off. I actually, I put a question
That's okay.
In the chat. Do you provide training to law enforcement officers on harm reduction as part of this initiative?
We do in conjunction with Tom Ross. We just did something down in southern Utah at St. George a few months ago. And we can provide additional treatment and put additional training and put them in contact with individuals who can provide them additional information on the receiving center, any type of other training that they might want.
Awesome. Wow, this is a really great initiative. Thank you so much for sharing. I've learned so much and I'm really encouraged to see all of the broad collaboration that's happening across these agencies. We've got another question in the chat. As part of the new CIS training, there's an increase of the education offered. Oh, I guess it's not a question. I have been active in Salt Lake City and doing training for new officers in Salt Lake City. I have educated on substances and use for CIS. Awesome. Are patients discharged from the hospital at Castleview on MOUD or MAT for alcohol use disorder? MAT is medically assisted treatment, and MOUD is medication for opioid use disorder.
I think that's a Bryan question.
Yeah, to answer that question, that is something that we provide as far as education and what those options are to make sure that it's something that we can coordinate if of interest. Yes, so that's something we do facilitate in the discharge plan. Awesome.
And I just want to echo everybody's comments about Savannah. I've gotten to know her just a little bit, and what an incredible human being. You're really lucky to have her on your team. All right. Thank you so much, Kasey, Bryan, Greg, Bill, and Steve for sharing your expertise with us today. We really appreciate you taking the time to be part of our summit. I wanted to let everyone know that we do have a rural law enforcement, incarceration, and mental health panel on Friday, where we're going to talk more about some of these issues. So I encourage you to join us then. And participants have your contact info if they want to reach out. And thank you so much. Our next session features a panel discussion that's focused on prevention, treatment, and recovery in Utah's Indigenous communities. We're proud to present 5 representatives from some of the area's leading treatment programs, including Roger Clark and Chris David of the Paiute Indian Tribe of Utah and FourPoints Health, Damon Polk of Red Circle Lodge, Scott Smid from Sacred Circle Healthcare, and Ashanti Moritz of Warrior Spirit Recovery. So that's coming up in about 5 minutes. Everyone can take a little break and we will be right back. All right, I'm back, everyone. I just wanted to share some of the responses from the chat about what is bringing people joy. A lot of people love their pets. I also love my pets. I had to lock them out of the room though today because they are getting in the way. My dog, he's 10 now, and I've had him since he was a baby. That's beautiful, Becca. Lynette, what brings me joy is seeing all the joint efforts to make change happen. Me too, Lynette. This is amazing. I'm so impressed by all of you who changed out of PJs. Oh, that was me. You're bringing me joy. I am joyful that Summit always incites new ideas or approaches to how we can help better serve people in our community. And it's another beautiful day out there today. Yes, thank you, Emily. My new tree in the yard. That's beautiful, Carol. Niece and nephew, the mountains, grandkids, anytime on the river. We are lucky to be alive and be part of this beautiful world. So now I am really excited about this next panel. We had a little meeting a couple of weeks ago, and I think you all are really going to enjoy this. This is the Indigenous Prevention, Treatment, and Recovery panel. And as our moderator, we have one of my favorite people, Michelle Chapuz. She's a member of the Ute Indian tribe, Uncompahgre band. Did I say that right, Michelle? Sorry. And she's a licensed substance use disorder counselor. And she's currently employed with the Ute Indian tribe's residential treatment program, Red Pine. She currently is serving on the board of directors for One Voice Recovery, which is a nonprofit syringe exchange program. She's also on the Perinatal Mortality Review Board and the accreditation board for Utah State University's Master of Public Health program. She has over 20 years of active participation in community outreach, health education, child abuse prevention, drug education, and prevention within tribal communities. And I got to work with Michelle for the past 6 months, and it was truly a pleasure. So I'm going to turn this over to you, Michelle, to introduce our panelists today.
Good morning, and thank you for that introduction. So I'm going to introduce our panelists today. First, we have Roger Clark. So Roger has worked for there you go. Roger has worked for the Paiute Indian tribe of Utah since 2015, when he started as an intern in the behavioral health field. He is presently the prevention coordinator for the tribe and oversees the Native Youth Program, providing substance abuse and suicide prevention. Roger has facilitated substance abuse groups and prevention groups, as well as providing individual mental health and substance abuse counseling. Roger received his Bachelor of Science degree from Southern Utah University in psychology and a master's degree in clinical mental health counseling from Alamosa University in Colorado. He is a board certified counselor with the National Board of Certified Counselors and is a licensed ACMHC. Roger has Paiute ancestry and is a longtime resident of Cedar City, where he grew up and finished high school. Roger and his wife, Leslie, have 5 children and 6 grandchildren. Thank you for joining us, Roger. Next, we have Chris David. Now, Chris, I'm going to have you pronounce your clans. So Chris was born on the ancestral lands of the Navajo Nation. He is a member of the Navajo tribe. His clans are
Thank
you. Chris's parents are Anna David and Edward David. Chris earned an Associates of Science degree from DSU, bachelor's degree in sociology and criminal justice from Southern Utah University, and a master's degree in clinical mental health counseling from the University of Phoenix. His relationship with the community is enhanced by the philosophy of walk in beauty, to walk in harmony with all things. As a counselor, Chris's approach is to incorporate Native American spirituality into psychological counseling with Native American clients. Chris has 6 children and 1 grandson. In his free time, Chris enjoys hiking and exploring the beautiful mountains of Southern Utah. Thank you, Chris, for joining us. Next, we have Damon Polk. Damon is a member of the San Carlos Apache tribe. Now, Damon, I'm going to have you announce your other tribe.
Born to the Kutzon Indian tribe.
Awesome. of Fort Yuma, California. He is a co-founder of the Red Circle Lodge, where he serves as the cultural director, substance abuse counselor, and on the marketing management team. The Red Circle Lodge offers inpatient treatment services for Native American adolescents. RCL utilizes the beautiful strength of Native American cultural practices as a natural foundation for healing. Balanced with proven Western treatment modalities, they create opportunities for individual motivation, growth, and vision towards healthy recovery. Damon provides cultural appropriate material and activities to complement individual and group treatment plans. Damon facilitates ongoing cultural competency training for staff development. Damon is humbled to be included in this exciting healing event. Damon resides in Cedar City, Utah with his wife, Dory, son, Julian, and their Chihuahua, Hazel Polk. Love that. Our next clinician we've got is Scott M. Smid. Scott is a licensed clinical social worker, program service director. After receiving his undergraduate degree from the University of Wisconsin-Madison, Scott has worked in the helping professions for nearly 28 years, starting in the field of substance use disorders. Scott has worked as a therapist, program manager coordinator, clinical director, and service manager director, working with a broad range of populations in the fields of mental, behavioral health, substance use disorder recovery treatment, adolescents and adults, and domestic violence treatments for victims, perpetrators, and child witnesses. Scott has served on multiple community committees in the field of substance use disorder and domestic violence treatment. Additionally, Scott has been active in giving back to the profession through direct work with the University of Utah Graduate School of Social Work as a field instructor, serving on the Field Practicum Placement Committee and being awarded Field Instructor of the Year for the years 2017 to 18. Scott comes to Sacred Circle Healthcare after serving as manager of outpatient recovery services at the University of Utah Neuropsychiatric Institute, UNI, for 12 years. While at UNI, Scott further developed treatment programming and was a participant in the development and execution of groundbreaking services and treatment for individuals with opioid use disorders. Scott had been a part of groundbreaking training and support to local police departments, new police recruits, and first responders in providing training and education on substance use disorders, substances of abuse in identification, and substance using behaviors, intoxication likely to be experienced in the field. Scott trained, educated hundreds of local officers through this programming. As Director of Recovery Programming at Sacred Circle Healthcare, Scott is charged with developing a service program team at Sacred Circle's Clinical at Pamela's Place in partnership with the Housing Authority of Salt Lake City. Scott is additionally responsible for the development and creation of a substance use recovery clinic services, substance use prevention in this recovery center. The Sacred Circle team will provide medication for addiction treatment, MAT, outpatient substance use disorder treatment, intensive outpatient treatment with foundational native-based culturally specific programming. Scott is a fanatical sports person. His pastime includes cheering for his beloved Badgers from Wisconsin, the Utes, and the Denver Broncos. He also loves spending time with his wonderful family, kids, and grandkids. Next, we have Ashanti. She's having some difficulty getting on, but let's introduce Ashanti. So Ashanti Moritz is the Business Development and Outreach Director for Warrior Spirit Recovery. She has a strong desire to help build connections for her community to provide tribal and non-tribal members a safe place to reconnect spiritually, mentally, physically, and emotionally to Native traditional healing practices. As a tribal member herself, as well as a person in long-time recovery, Ashanti has personally experienced the benefits of when a community comes together and creates space for healing in traditional ways. Warrior Spirit Recovery is a White Bison affiliated residential treatment facility located in Tooele, Utah, owned and operated by the Skull Valley Band of Ghost Shoots, serving both tribal and non-tribal members to bring together a healing process that addresses the needs of each individual in open space, allowing personal growth. Warrior Spirit has both male and female programs, each having different locations to provide a safe environment to reconnect with oneself. Ashanti's role there has been to build bridges to the communities surrounding Tooele, Utah, to help create and foster relationships with health care providers, community services, and bring an awareness of recovery to those seeking services. So thank you so very much, all of you, for joining us today. All right, so my name once again is Michelle Chapuz. I'm going to be the moderator for this panel. We've had a beautiful introduction of our panelists. We are going, if you have, let's see, if you have any questions, we have, Katie is going to be watching our chat box. So let's go ahead and start. All right, so this panel summary. So the summary of this panel is that we're going to discuss the specific issues faced by Indigenous communities and people with regards to substance use disorder, prevention, treatment, and recovery. So we have experts from 4 of our Indigenous treatment and recovery centers in Utah. They'll discuss their work and the importance of respecting culture in treatment and recovery. All right, so we're going to jump right into this because this is a good conversation to have, right? So the theme for our questions today is going to be bridging harm reduction and recovery in rural communities. Sometimes there is tension between recovery services that focus on abstinence from drugs and harm reduction services for people who currently use drugs, like syringe distribution programs. So we're just going to go on down the line. We'll start with Damon. He's the first one up in the corner for me. So how do you define harm reduction, Damon?
Okay, Michelle, before we get started, I really feel humbled to be here, and I appreciate all the participants. In Native America, we have in the course of our ceremonial ways, and I'm gonna go back to that periodically through this, and the concepts of taken from Gona, or borrowed from, or shared from Gona. The concepts of belonging, mastery, interdependence, and generosity are components of our ceremonial life. And coming here, and we have a beginning, and I'd like to, if you can indulge me, because we come from the field, we come from Indian country, we come from working and working from our heart, and so. In that context, I'd like to request some indulgence as we take care, and then for our participants also to find a safe place, for us to find a safe place, so that we can share in a humble manner about this very important topic. So if you can indulge me for just a moment, I want to take care of that for each one of us right now. And because this is a rural and tribal summit, and we're talking about folks at home who may not have access, who are looking and seeking and trying to find a way in our way, and I don't want to infringe, but I believe it's important, because that's who we are. In our tribal ways, we use what's called a hanal, and within this, there are all the sounds of the world, all the sounds in the universe. So for those of you who are able to close your eyes for just a second, then we'll take care of this. And this song goes out to each one of you and where you're at right now. And I know it's in a virtual place, a virtual platform, but then of course face to face is great, but then it's what we have right now. So I want to take care of that before we go into this session. We know you and I come well. We know you. The call in each of the directions at the end of that song, and all its songs are to let our relatives in each of the four directions know what we're doing. We call the spirits to come and look at what we're working on here today, where our heart is today, and for each one of you to have, and it doesn't matter. See, our Creator has no prejudices, and so we're all working on on the same issue, and it impacts everyone. And so in that, there's a prayer that goes out to each one of us. And I love prayer. And sometimes that's all we have as we do the work. Harm reduction in the most simple form is to lessen the harmful impacts on our life. Collaborated efforts are most effective, but it takes humility in order to be inclusive and to be a part of the circle, to find a sense of belonging in those efforts. Harm reduction, we look around and we recognize what is harming our community, what is squashing the visions of our young people and their aspirations, and that of our elders. When we sing our songs and our elders get happy. And I know that because I'm an elder, and I get happy when I see, and I walk into my job site and I hear our kids singing, and many of them are not even from bird singing tribes. They don't know a song, but they know that's a song enough to sing it on their own, and that's inspiring to me. All these things I love collaboration. I love the collaboration efforts of, let's say, communities that care. Matt and other things, tribal and Indian issues, those kinds of collaborated efforts to identify resources that are available for the issues at hand. But yeah, that's my definition of harm reduction.
Thank you, Damon. So Scott, do you want to add anything to that?
Wow. Again, I'm humbled to be a part of this panel, following that amazing song, and prayer is humbling to say the least. And so much of harm reduction oftentimes is just almost the excusing of or the allowance of people to use, but use less. My hope is that as we have this panel discussion, that we're able to look at the language of opportunity and the recognition of what all of the journeys of recovery look like, not just one that's abstinence only, and that we open to all of the possibilities of the recovery journey.
Thank you, Scott. Chris, would you like to add what your definition of harm reduction is?
Yeah, good morning. Again, too, I'm very humbled to be here. I'm very honored. I want to express my appreciation to my Sundance brother, Damon Polk, for offering that song and prayer for us. And that's what it's all about. And there's something that he said that was very important when he talked. He says the Creator is unprejudiced towards things. And that's just that about our programming and our approach is harm reduction. We offer a lot of services with prevention sites, anything harm reduction related, programming, stuff like that. It's all about serving all. It's all about taking the word discrimination out. It's meeting people where they are in their treatment. It's having dignity for their treatment. It's having dignity for who they are. As we go forward, you'll find that, a lot of these programs, these harm reduction programs, a lot of it's not linear. There's a lot of components to it. There's a lot of different variables to it. So as we learn more, because I'm a student, I learned a lot about this morning's discussion when those two people talked this morning. I'm learning just as everybody else is. I think harm reduction is a very compassionate, very non-judgmental approach to reduce blood-borne infections, to eliminate fatal overdose. So what are programming strategies that we can collaborate with and come up with? I think that's a win-win situation. And I think there's a lot of research that needs to be done. A lot of negative stigmas that come along with harm reduction. Just like mental health was, way back, it was considered evil, it was considered, broken. But as we did more research, people with mental health that have suffered with depression or anxiety are good people, they're productive people. So people with substance abuse, they are good people, and they have challenges just like anybody else does. So establishing positive supports and harm reduction and establishing supports with our rural communities on Indian reservations is very important. So that would be my input on that question. Thank you.
Thank you, Chris. Ashanti, how do you define harm reduction?
Good morning, Michelle. Good morning, everybody. I'm so grateful to be here and so excited to be part of this discussion. So much of every question means so much to me, and for our community as well. Harm reduction, I really believe, is creating a space, an environment where people can feel safe and feel loved and honored no matter where they are on this journey. There's been so many wonderful answers already, like just taking out the prejudice and just really being humble and able to see that we can't change people, but we can change some factors to what they're experiencing, and those factors that we have the ability to, reach on different levels, those are huge. We can take people, you take away the different diseases that come with it, and you take away the harm that it does to their body and the shame and the guilt from needing those things, is really what harm reduction is truly about. I read this article and it talked about providing different uses for safe sex and how that was harm reduction, and providing space for that for all sorts of different levels. That's huge. I mean, that right there changes the game to say, you know what, I see where your struggle is and I see the pain that you're walking in. What can I do to bring less pain in that situation? And as a healthcare provider or somebody in the community, that's like what we strive to do is to sit with people and to create a space and to say, regardless of what your struggle is, you are worthy of love, you are seen and you are heard, and we're here to sit together with you through this. And so that's my definition of harm reduction.
Thank you, Ashanti. Roger, would you like to add on to what your definition of harm reduction is?
Sure. Thank you, Michelle. First of all, when I came to this job here at the Paiute Indian Tribe of Utah, I was honored with the opportunity to work with Damon for a while, till he took off and left us all stranded. But anyway, I just like to let him know that I learned more from Damon in probably 2 or 3 months than I did through, the whole college career stuff. And so he was a really valuable mentor to me. And then Chris David showed up and taught me about harmony and things like that. And so, I was in a position where, I wasn't able to practice Native American cultures because of my past and, the boarding schools and hiding our heritage and things like that. So it was a real pleasure to come to work at the Paiute tribe. But what I've learned here and, through about harm reduction and things like that. And, talking to Chris David, we've talked many times about harmony in life. And just like to show you this Native American style flute. And the way that this flute is designed is to have harmony in it. And it's a reflection of the harmony of Native America, how everything has a purpose, everything has a plan, everything goes from one thing to the other and takes from one to the other and moves to the other. And so it's kind of like what we got from Damon, you know, when I first moved into this position. You know, he taught me a lot of things, and the things that I was able to learn from him, I'm able to take out into, you know, our youth programs and things like that. And the same with Chris David, you know, to learn these things and be able to take them out into public and things. But because of this, we were able to have harmony with one another. And again, like I said, you know, the Native American flute, the way it's designed is all the notes are in harmony with one another. And so when you play the songs on the flute, you don't have to think about the music. You think about what's in your heart, and it comes out in harmony. So I'd like to play one little short song with this, with the Native American style flute here, to kind of set the mood and show you a little bit about the harmony of the flute. Anyway, with harm reduction, if we were just to take it down and maybe just go with the definition of harm, 3 little words there: injure, damage, and hurt. If you think about those 3 words, injure, damage, and hurt, and you pull those into different parts of our lives, I mean, when you first hear those, you think about injure, damage, hurt. Well, that's physical. You know, I'm injured, I broke a leg, I'm damaged, you know, damaged the skin or something like that, hurt, sprain an ankle or things like that. But you can take those 3 words and you can move them into, what if you move it into family relationships? Hurt, damage, or injure. You know, we bring things into our lives and you know, maybe substances or things like that. And using those 3 words, how can that affect a relationship? How can it affect your employment? How can it affect, you know, many aspects of life? And what that has done is it's pulled us out of harmony. And so as it's pulled us out of harmony, then we start to feel these things, and it disharmonizes all different areas of our lives. And so to bring us back into, or harm reduction, is to pull our lives back into harmony, to, you know, involve the community support that we have, the family support that we have, the services that, you know, our tribe has to offer to people, to be able to pull our lives back into harmony so that we can be one with the Creator, one with our lives, one with all these things that are so important to us. And what it does is it brings healing back into our lives, that we're able to proceed and be able to create a good life and move forward with that. So I'll leave it about there with that. Thank you, Michelle.
Awesome, thank you. You guys noticed a lot of when we start talking about harm reduction, there's some components that everybody talked about, which is love, honor, removing stigma, opportunity, and harmony. So, you know, when we look at harm reduction, we can see that it's, you know, with Roger talking about removing injured, you know, people are injured, damaged, or hurt. How do we heal? So with that, I'm just going to open this up for anybody who would like to add anything else to this conversation about what harm reduction is and how it encompasses love, honor, removing stigma, opportunity, and harmony. So jump on in, anybody on the panel.
I think when we had our conversation last week or the week before, really looking at that piece of the individual and really recognizing the individual and how the individual fits into their personal identity, their tribal identity, their larger community entity, and what that individual piece is and where you're going, what your what your idea of self and success and how we get there. It's individual for everybody, and the opportunity to help people on those journeys is so important and gives opportunity rather than shutting any doors.
Thank you. Anyone else? All right, so we're going to go ahead and quickly move on, because you can see how this is such an amazing conversation. And once again, I want to express my gratitude to Damon and Roger for opening up the way you did. That is greatly appreciated. And I know for all of our Indigenous participants, that's a key component to beginning any sort of conversation, especially when it comes to difficult topics. And Roger, thank you for sharing your flute. That was a beautiful thing, and harmony is amazing. So with that, how do you think harm reduction and recovery can work together to help people in rural Indigenous communities? And I'm going to leave that open for anybody who would like to chime in first. Or I can start pointing fingers. Let's start with Chris. Chris, if you could let us know how do you think harm reduction and recovery can work together to help people in rural Indigenous communities?
Hi, thanks, Michelle. That's a very, very good question. I'm sitting here pondering how we can, bridge that together. I think one key thing that comes to mind is education and building awareness of what it is and how we can support that. As I mentioned earlier, there's a lot of components to this, but I really think awareness, bringing even evidence, spiritual-based practices into what can help cultural inclusion is definitely a big thing as well. So I think education and awareness is key in all of this. Then again, as I said, I'm just a student in all of this as well, but I think those two components are very important. Thank you.
Thank you, Chris. Ashanti, what would you like to add to that?
So harm reduction and recovery, it is so important to have these two. I remember when I first started doing outreach for Warrior Spirit, I would literally see people that were struggling on the street and like pull over and be like, I have some water, I have my card, like, what can I do for you? I usually have snacks in my car everywhere I go. And so I'd be like, do you need granola bars? And to me, like a lot of those people actually ended up reaching out and calling us and being like, hey, thanks for, like that water or that. So that harmony and that balance, when you create a space for somebody and you start seeing whatever their needs are, and you can just be okay with it, just be okay with what their needs are. You don't want anything else, you're not demanding anything from them, but you're like, I just want to provide you some love. And I think that when you bring that type of harm reduction into your space where you're providing treatment services, residential, IOP, whatever level it is, right? They're gaining these little seeds. And in those seeds, these self-growths and self-changes, they develop and they start seeing things differently. Like I mattered so much, somebody pulled over and gave me a bottle of water, right? Like that is huge. Sometimes you can go unseen for so long, and to have someone just notice your existence and be like, I'm here for you. That can just change everything. So when that happens inside of a residential facility or an IOP room and a group of people, and somebody doesn't say stuff for 3 groups, and instead of demanding that they talk or opening, up, you just put your hand on their shoulder and just, hey, thanks for coming tonight, when they're alone, and you have that space, that opportunity to do that. That person is going to, have a little seed planted inside of them, and they're going to feel connected. And that is so fundamental to change is the connection. And that's what we're looking for. That's what I feel we're looking for. I'll just leave it there.
Thanks, Ashanti. Damon, what are your thoughts?
Oh, Mr. Polk, you're muted.
Yeah, man, I got going and then I forgot to press the unmute. But okay, one of the things that when we begin a ceremony, please know that the person who's initiating that and gonna call the spirits, and the spirits are gonna answer, and they're gonna come and they're gonna sit and they're gonna take. They're gonna come and they're gonna stand by you, each one. They're gonna recognize the strengths you bring to a circle to focus on a particular. When we put cedar down, putting cedar down is a humble movement. But before we put that down, we have to sift it out a little bit. We have to clean it out. And there's a process in doing that. It is very humbling that the young people that I work with, their folks, their grandfolks, their tribal people, they'll send medicine like cedar from their area or sage. And our kids are the ones who are responsible to take that and clean it out and to prepare it so that it can be used. And so each one of them is like this medicine, and they come and they bring their heart, they bring their circle, even if that circle is broken, even if they have ill thoughts about how they come to be there, away from their homes. And we call the spirits to come and to move that energy, just like right here, the comments that you're making, that's energy. The thoughts that, the thought, and we want to provoke thought from all participants, because we know where your heart is, that we have something in common. We have more in common than we have differences, please know. And because we belong, we're allowing that spirit to come and to move us and to move this energy, to channel it into a productive direction. And all around us, our desired outcome is the same. It takes humility to collaborate. I believe that harm reduction and recovery work together. Our desired outcome is recovery and quality of life, longevity of life, those kinds of things. I believe, just because I'm a believer in healing. I'm a believer in healing practices. And so when someone comes and says, hey, have you tried this? And in Indian country, we have our stigmas, and they're very valid ones. So with that being said, somebody has to take an initiative and to break down the barriers that prohibit us from working together or create obstacles. And I see these kids collaborate, and it inspires me. It inspires me to help them to open up those gates and take those barriers down, to take them down, to allow, I don't know, a belief to grow. We're all connected. We're all connected by spirit. All the instruments. I really appreciate Roger's piece there, his sharing, and that everything comes from say when he makes that, when he takes the breath and then he blows that out there, and it goes through this process into the world, and it initiates things like love. And I would tease him. I said, oh, because my office was right next to that conference room, and then I can hear him, and then then, you know, I can see him evolve into his music evolve. And so the outcome is that, you know, we believe that flute has love properties. You know, I said, you're going to get everybody. It's either there's going to be something that happens. Either you're going to make everybody fall in love, or you're going to have a bunch of mice following you. And so I would tease him like that, and then you know, and it's all in good fun, because I appreciate his spirit, because his spirit goes, that spirit of all those goes into prayer, and that's like self-care to me, and it's for my care. But yeah, I believe that if we work together, then there's no other way. We're better together. Oh.
Thank you, Damon. Roger, would you like to add?
Yes, thank you. Yes, Damon created a monster with this flute in me. It's got to the point that it's like my whole life revolves around it now. But there was a time when back in the first days, we'd be playing around a little bit, and Chris Bagby was here, and he taught me how to play the flute and be out there playing. And Damon grabbed me one day at one of our gatherings, and the microphone was hooked up. He says, "Roger, come out and play." Oh, no. He says, "Roger, come out and play." So I went out and played in front of all those people, and my life's never been the same since. But it's all Damon's fault. He created a monster. Anyway, you know, I think about that question, Michelle, about that, you know, how can a rural community help out with these things? You know, us being in a community setting, a community society, you know, it seems like that everybody takes a little bit part in recovery. When you have a person that's gone through some real tough things, and you know, get some addiction problems and things like that, and abuse comes up in their lives, and all the not bad things that follow behind it. If, you know, once the community gets involved, it seems like the whole community takes a little piece of that. They have a little bit of their own personality in the recovery of this person, and with that, you know, the strong supports come along. And you know, I just wonder if at times when we have somebody that's in recovery and we know where they're going to go back to, are they going to go back to the family, or are they going to a halfway house, or whatever it might be? But if it happens to be maybe going back to the family, it might be a good idea for us to spend some time with education of that family. You know, this is how things have changed. This is what your family member has gone through. This is the support that they need in these areas and things like that. But once we get the whole community involved with that, you know, most of the tribes out there like ours, relatives, you know, there's a lot of relatives within our tribe. It seems like everybody's related to somebody in some way. And so, you know, the blood relations that we have there, the biological pull that people have to one another, you know, creates that support system. And then, you know, pulling the culture of Native America in there, the oneness of the community. And again, here comes that word, you know, the harmony of the community as it's created there. You know, harmony, this harmony is created when, you know, somebody is hurting and they enter into the society. And if we can, as a community, you know, gather together and support these people, support them in their sobriety, support them in their recovery, and they're able to come out of this, it creates harmony for everybody, and everybody feels that oneness, feels the love for one another, and be able to be pulled together, and you know, and creates that strength for one another. So anyway, that's about it for me. Thank you.
Awesome, thank you. Scott, how do you think harm reduction and recovery can work together?
Wow, sorry, I'm transitioning from student to panelist, and so excuse me for my. I'm amazed and again humbled. Learning from everybody, as hopefully everyone is, really looking at this question and how we do things. I would agree 100% that the treatment and harm reduction, they go together. And as listening to Roger, the idea of harmony isn't sort of the recognition that everyone needs to be the same. It's sort of the conflagration of multiple tones or multiple individuals to create that one sort of combined and collaborative direction. So there really can't be differentiation, because this disease, this disrepair, as Roger said, that the disease gives us individuality in every one experience that any individual will go through. The idea of trying to jam everyone through a single treatment hole, that this is how and what it looks like, can't make sense. There's no truth there. And looking at one's individual journey while they're in treatment, and then sending folks back off into life with new instruments of harmony and new opportunities to create their individual path within the construct of their culture and their family and their community. There's never any one thing in there. It's always a whole that we all are a piece of.
Awesome, thank you guys. So we can see that harm reduction and recovery can walk hand in hand, but it's an individual, like Scott had mentioned, and all of our panelists have mentioned, it's an individual journey, and there are many ways to get there. And I know we've talked about this, but I would like to kind of go a little bit more in depth. How is culture an essential component to treatment and recovery? So how do you bring cultural protective factors into the healing process, knowing that harm reduction and recovery can walk hand in hand? How is that cultural component? And I'm going to start with Ashanti on that one.
Thank you, Michelle. Culture and thank you, everybody. This is just such an amazing opportunity to be here and to hear everybody and to know that what we are doing, we're all so far apart, but a lot of times we're all working together. I see a lot of people in the community that I know and I work with, and I'm super grateful that this is a path that we're all on together. I would say that culture and recovery for me, because I'm a person in long-term recovery, and so I felt like I went from place to place to place to place to place, and I was always searching and always looking for something that felt like it was missing. I would get so many seeds and so much hope from different treatments and different programs and different avenues. There's AA, NA, CA, Al-Anon, and I would just feel like, oh man, there's something else that I really just am searching for, and I didn't know kind of what it was. And then I had this wonderful opportunity to get directed to the Urban Indian Walk-In Center, and I met this fantastic woman that changed my life and put me on a path that I could never even imagine being on, and she means so much to me. She absolutely is one of just like this mentor in my life that I will just forever be grateful for. And she sent me to Colorado to do some white bison training, which is Wheelbriety, medicine wheel, and all of a sudden I was in there, and maybe within the first 2 hours of learning this part of the program so that I could bring it back to the Urban Indian Walk-In Center, I took a breath and it felt so full. And I was like, this is what I have been missing on my journey. And it was cultural, and it was creating a circle and creating a space and creating prayers and using drums and music and songs and it was all of this that I needed so that I could continue on this journey and feel fulfilled. And it was this spiritual aspect of my culture and my people. And it felt like home, you know, like all of my ancestors all at once just put their hands down and we all just kind of rejoiced together. And that's what it really did feel like. I was like, this is amazing and fantastic. And to be able to bring that culture and to understand the importance of cedar and to know it and to understand the importance of water and to bring, you know, bring together in a talking circle and to have customs and ways and honored because they're all different. We're all different. We all bring our own differences and all of our medicine wheel and our, you know, all of that is different everywhere you go, but to have it honored in recovery has been an amazing journey. And I see it just all the time with our clients. They just, oh man, they didn't know that the drum spoke to them that way, or they didn't know that prayer and smudging just opened up different doors for them. And you can see it react in their eyes and in their spirit. And then they bring it home to wherever home is, and they've, you know, grown a new connection to it. And it feels really to have that part of the culture and to understand that this is where I'm from and honor it, because I used to feel like, you know, oh man, because I'm Native, this is alcoholism. This was something that went hand in hand, and it's that stigma. And it was this key, the cultural love, it was this key that freed me from that stigma within myself. And I love it when I see that stigma get broken, you know, like, and people have a different understanding of their culture there. I really love it.
Thank you for sharing that, Ashanti. Chris, would you like to add on what you feel about why culture is essential component to treatment?
Yeah, I think culture brings true belonging. It brings healing. It's a form of resiliency. And as a mental health clinician, you know, I attend all of these trainings with internal family systems and cognitive behavioral techniques, DBT skills, EMDR. And what's really interesting is all of these components, it's like, you know, as Native Americans, we have these practices. We've had them forever. And the community, a mental health community, you know, the research and all of that, sure, we have to validate research, right, to be evidence-based. But it's been there within our culture. It's been there. And practices, ceremonial practices, such as, you know, the Sundance, the Vision Quest, and the Sweat, all of that is pure mindfulness. All of that is centered towards self-healing. It's not only in our spiritual practices, but, you know, in language itself. The words that we use, you know, Hajona Nestle in Navajo, returning back to one, returning back to beauty ways. You know, Madaki Oyasin, it's a very powerful term. Terms like Shiyaja, those words are healing. In those moments that we say in ceremony, as Damon refers to, the songs that we hear, they're not just songs. They're stories of our people. They're stories of healing, resiliency, warriorhood. There's so much there. Going to the history of our people, as a Dene man looking back in my culture, my history of the long walk, I see what my ancestors have gone through. And I'm so privileged to have their blessings today. I've seen how long they've come. They've sacrificed so much. Question is, what can I do with my education? What can I do with my knowledge? Give back to the people as my ancestors did. That's part of our history, learning that. Understanding our roles Men, women, children, eldership have roles. These roles are essential. It's a medicine for us. And I can see my brother Damon bringing that song. That's his responsibility. And we honor him in that space. I have my responsibility. Roger does as well. We all do. Ashanti mentioned something about customs. We all have customs. Learning to understand what our traditional customs are. There is protocol, there is procedure there. And all of that is a form of healing. So cultural inclusion, cultural and integration is very important. Our language is very important. So yeah, it is essential. Thank you.
Thank you, Chris. Roger, would you like to add anything onto how culture is essential, an essential component?
Yeah, as soon as I can find the microphone, there we go. Yeah, culture, an essential component. We have several grants that we operate the Native Youth Program off from, and the kind of the theme that we go by is culture is prevention. And so we kind of stay on that. And, that this was brought up a long time ago. And when I first started with the tribe as an intern, of course, I got to cross paths with Damon. Damon taught me how to do Red Road to Sobriety. He taught me how to do the smudge the correct way of directions and all the importance of those things. And so, we brought those all into our Red Road to Sobriety programs. And being an intern, I ran that for a number of years, and got to meet a lot of people with that. But a couple of interesting things that I really found about how important culture is we brought that in, and then sometimes the AA meetings in town, they couldn't have those, and so they'd come out to the tribe. We would advertise that that's available, so they'd come out, and usually on the Monday nights and Thursday night programs that we had there. And when they would come in and they partake a little bit of the culture and things like that, they would keep coming back because they said, there's a different feeling here. And so, as I, view this and started thinking about this, oftentimes we forget about the power that the culture has, about the Native American culture. If we were to turn back the hands of time, go back, I'll say 700 years prior to 1492 when Columbus came, so let's say 1491 and before, we go back to the foundation of our spirits and things like that, and go back to the basics, as Chris just talked about, was addiction a problem then? I don't know that it was. It was, if there was a Paiute meeting or something like that, and it was used for spiritual purposes, and it had a real foundation behind it. But the fact that addiction probably wasn't part of it, but the culture remained on, and the basics of the culture remained on. And, all of our ancestors took it in, and it was such a big part of their lives. There was one, I want to tell you the story. There was this one time I was sitting in Red Road, and, it was a night, and we had a few people in there, and we had this couple came in, and he said, God, I'm glad I found this place. We looked all over town for it. I had a trailer breakdown on the outside of town, and the AA meetings are like the thing that keep me going. And so I had to find this place. And so I was able to find it. And so here we are. And so we went through the program, and we come to find out about this gentleman. He actually had a couple of NASCAR race cars, and he was heading to Las Vegas to race them, and had a breakdown with the trailer. And so he ended up in Cedar City, of all places. And he had a big talk show in Florida, and the population and ratings and stuff like that is about 10 million people that would listen to him. And so he came in, and he sat down, and we went through the program and things like that. And it got to Damon gave me an okay to play a flute at the end of the flute song at the end of the program, just prior to the Native American prayer where we would close. And so we ended up doing that. We went through the whole program, what we usually do, and then we ended with, did the smudging. We ended with the flute song, and then with the Native American prayer. And he stayed after, him and his wife stayed after. He said, I've been going to AA meetings for 30 years. And he says, I've never been to anything like this. He says, I never knew how impactful this culture can be on a person. And so, a lot of times we might discount how important this culture is, about how much it can bring to the people. Being from the outside and, with Native American heritage, and then coming in and be able to partake of the culture and be able to enjoy it really gives it a value for me. Those of us who have lived in it all our lives and be able to partake of this wonderful culture, sometimes maybe don't realize the value that other people can feel in it. So from time to time, I get a message from this guy thanking me again, and how much it changed his life to be able to see the basic of our spiritual foundations, and how much it can move a person and how much value it can bring to a person. And so when we think about the culture and how it can be part of it, the recovery, and be so important of the recovery, we can't discount it. We need to realize the value that it has for everybody, those in recovery, and everybody around us. So thank you.
Thank you, Roger. Scott, I like what you put into the chat box. Can you share that with us? Was that you?
I in listening to Ashanti, and she's great, and I wonder who she might have been talking about. But I wrote that if an individual is to invest and fully engage in treatment, there's got to be elements of culture and the individual interwoven into what treatment looks like. The sad reality of the treatment statistics, I guess, is that people engage in multiple 6 to 9 treatment episodes is statistically where we're at before they get it, before they sort of find their thing. And I think a lot of that has to is motivational, but I think there's also a piece that there's not the investment because it doesn't speak to their self, their culture, or their understanding of themselves as an individual. So when there is the opportunity that treatment can interweave elements of culture, elements of the self, and understanding the interplay of those things, that's when there's staying power, and that there's increased investment and worth to any individual. Those are the things that keep people coming, keep people, and like Roger was saying, that it sticks around, and people recognize that as super valuable and long-term to their success.
Thank you for that, Scott. Damon, culture, an essential component to treatment and recovery. Share your thoughts.
Our native culture is the foundation of our life. It allows me to see and recognize the truth of my walk without running away again. It says, stay in the circle entirely until it's done, until it's complete, meaning the ceremony and life. Our ceremonies allowed me to stay and find peace and to forgive and continue in this life. We each have work to do here, so we're not done yet. Breathe and hum often. What are those things that allow you to breathe, really breathe? When trauma presents itself abruptly, or because it happens so frequently, it's almost an expectation, then I hold my breath, and how much of that breath is still left inside. Ceremony creates an opportunity for that breath to come out. There was identified in studies that there are 40 essentials of growing healthy children. Expression is an essential. Validity, getting validated, getting recognized is an essential. And I know that people mean well when they say, oh, I don't see color. But what happens when I come in the room, and when I come into the room, mostly people will see a Native American man. But if they don't see color, they're negating who I am and maybe ignoring that. When our children go into a school where there's approximately 2,000 and they're less than 1.4% of that population, but then, adolescents are kind of mean. How do they take that? Do they have a sense of belonging? Our culture is an essential because it's alive, it's living, and we have to feed it. 500 years plus after European contact, we're still here and we're singing our songs. There was a time when that was outlawed. I believe in 1978, Freedom of Religion Act allowed us to practice without penalty. But we've been breathing all along. And so again, those are essentials. You look at the essentials in your everyday life. The phone is kind of essential. So, because we got to do our text messaging and, drive with our knees sometimes and, putting on, kind of brushing up your lip gloss and stuff before you head on to your destination. But yeah, and I say that, because I tease a lot but again, you look at the essentials, breathing is essential. So let's do that. And if you can do that now, because there's a lot of heavy duty stuff going on right now, especially with this topic and especially with the topic of in general at the summit. So take time to breathe and take care of yourself.
Thank you, Damon. That kind of leads exactly right into what we're going to talk about next, because we're talking about what we want to talk about next is the importance of being vigilant in preventing substance abuse in our youth under the age of 25. And why do you think the Indigenous youth population has higher occurrences of substance addiction than other populations? So Damon really led into that when you talked about, the 40 essential things that we need to do in raising healthy children. So I'm going to go to Scott for this one, and then we'll move on through. So Scott, what are your thoughts?
I think that sort of looking at how we address youth is super important because they're in this identity formation life stage and recognition of their individual representation of the self, how they reflect and represent themselves in their community, in their tribe, in their family, in their everything. So looking at the development and the developmental place of their life to try to understand that identity formation needs to look like and needs to be stretched by some of the challenges that are experienced, and learning appropriate and pro-identity, pro-tribe, pro-cultural mechanisms to learn who they are. If there is reliance on substances, if there is reliance on maladaptive measures to create a sense of self, it's really quite the opposite, sort of the delusion of that identity formation.
Awesome, thank you. Chris, can you add on to that?
Yeah, taking a look at those two terms, those two words, high occurrences. and youth. My thoughts are, we have to count at some point, address historical trauma, how that's impacted our youth today, how that's impacted the generation before us and the generation before us. Then again, I'm looking at, as Scott, mentioned, the identity of who we are and what we do. I'll go back to ceremony and customs again. Taking a look at our roles, where those teachings are set in place. So I really think that addressing historical trauma, and the last question on here was also, what can non-Indigenous people do to support, this cause is being aware of the history, being aware of the suffering, acknowledging what the suffering the people have gone through that still are suffering to this day. So I like to think that, would things be different, as Roger said earlier, would things be different, back, before the Columbus days? What were things like? Did our youth struggle? What was that look? How were things taken care of during those times? Then again, I think cultural practices play a really important role in all of this too. So in my community, our men, my age and the generation before struggled. It's sad to say that, when we have spiritual or cultural events, I am looking for elders to step up. And sometimes it is hard because maybe they are ashamed to step up. Maybe they are embarrassed or not feeling worthy of stepping up and offering up a simple prayer or even talking to the youth. Something's going on there. What is it that's going on? So is it stemming to the loss of identity? Is it stemming to shame, the boarding schools, the assimilation eras, the kill the Indian, save the man mentality? I think those things still impact us because I'm the second generation, a secondary post traumatic stress syndrome. My dad suffered a lot of boarding school, injuries and traumas in his day. And I remember going up to college here. He says, Chris, don't burn cedar when you come up. And I always thought he was a jerk for doing that, for saying that. But really, he was protecting me because he didn't want me to be criticized or judged or to be counted out. Because in his mind, that was a bad thing. He protected me that way. And it took me a long time to understand that. Years and years of doing my own work. So at some point, I think historical trauma has to be addressed. So thank you.
Thank you. Damon, I'm going to have you expand a little bit more on what you had said prior, leading into this conversation.
Okay, certainly. I really appreciate the recognition of historical trauma. And please know that when we put it out there, it's not to blame. And it's still impactful. We're generations. I look at the young people that I work with, and the best thing that I can do for them is to model behavior, is to be consistent, and to stay to the prayer and stay to the belief that our culture is alive. Our traditions are about living, about celebrating life, and how to do that in an appropriate way. Is to model that behavior and have that belief and be able to understand that there are disciplines that are so innate and so present that I don't need a Bill of Rights to be reminded of what my rights are, that I don't need a 10 Commandments. And I don't say that with disrespect because I don't have to have that posted anywhere, because there's a teaching that is about the truth. And the truth is only what it is. It's not what I want it to be sometimes. It's just the truth. And I'm tired of running away from it. My ceremonies allow me to stay and be brave. We have songs about that summon up this courage, even though I want to run, even though it frightens me to death, because I've seen things in life that children should not see. These young people have seen that. So because I want to blanket I want to push this trauma that I've seen and been a part of, that I was pulled into. And maybe I in order to do that, I display negative behaviors. You know, we have an attitude about substance abuse, substance use and abuse, and recovery and healing. And this attitude carried over many generations, and it contributes to our views of healthcare, what it looks like and who's entitled to that, education, housing, etc. All those components that are essential for me to have a better quality of life if I'm deserving. And I've come to find out, and I've worked in many arenas. I worked in the public school system. I worked in elementary education. I have a background in early childhood development. When I left from California, I was a director of a child care program. I was on school board there. All these things contributed. There was an attitude amongst the Indian community. And so looking at that, it has formed our expectations of quality of life and longevity. The opportunity to create and support vision for our youth is always a goal for agencies throughout Indian country. And I've been in I've sat in ceremonies throughout Native America in my time, from ocean to ocean and border to border and beyond. And we only have the borders because they were implemented by the government. We have people from Guzan who are in Mexico. There are Cocopa people, rancheros in Mexico, and so on. And the Blackfoot, they have relatives in Canada, and they're only separated by that border. And this was Native territory. This is Indian territory. It's Indian country, and we still believe that. And we're sharing people. And so the concept of harm reduction, when it comes to, we're sharing people. We want to be able to share the resources. And so, and I tell the kids, I said, I love it when you give me attitude, and I'll hear you and I'll listen to you and I'll absorb your attitude, but I want you to back it up. I want you to back it up with something good. And tell me about your blames. Tell me about what you think and things like that, and see what we can do. Because I'd rather have you tell me that than you swallow that and try to live and try to digest and try to clear your head. I said, in the meantime, let's go cut this wood. Let's stack this wood. Let's get ready. Let's cover this lodge. Let's sit down and sing. Let's sing so loud that our folks can hear us back home. And so it continues. Being vigilant means many things to me. It means consistent. It means to stay in the song. Don't be in such a hurry to get through the song or the ceremony. Stay here for a little while. In our ceremonies that last over a few days, then sometimes we want, like, our minds are already outside and what we're going to do. Let's stay here. The Creator's bringing our relatives to come, and let's be patient and wait for them, and understand that that's why I'm here. That's why we're here, and to be able to be good with that. There's so many components to this prevention. Prevention means before it happens. So when do we talk to them? I talked about, I want to give the persona, I want to give an attitude, I want to give a demeanor of prevention, that it's not okay to use alcohol or drugs or smoke cigarettes or whatever. And then in one of my talks to our young people, for elementary kids, and I'll say, every time you hear me say it, drugs or whatever, then you say yuck. And so we got the whole, so I'd go into this random story about, Paiute, And so every time I'd say cigarettes, he picked up a cigarette butt, and then they'd go, yuck, it's cool, because that energy is what drives us to get them to do that. And I said, I want you to do that. I want you to do that at home. And I don't know if they ever did. I don't keep data on that, but and so we're sometimes, in Indian country, I just want to get that conversation out there and let them know it's okay. But yeah, and I can only be more vigilant when I'm well, when I'm healthy and well in all aspects. Thank you.
Thank you, Damon. Ashanti, what are your thoughts?
Wow, this is I had to take a few deep breaths through that. There's a lot right here, and there's a lot definitely that come from childhood that you bring into adulthood. I think one of my favorite things that my dad used to say is, you're not a full-grown human until you're 30. And I can really appreciate that a lot more, because the experiences and the responses and the interactions that you have with people, I love how this is like youth up until 25, right? That says a lot, that says a lot to where the brain goes and how it's still developing and what experiences that are still forming through college. I think that man, this is, I think that the experiences that we develop, I'm reading a really good book by Oprah right now, and it is like, Who Am I? Or something like that. I don't know the title, but it is absolutely amazing. And it talks about all of these different stages and different experiences that you're going through. And I think that looking back in my life, some of my most favorite memories growing up are going to Sundance and going to powwow and feeling like the spinning as you're dancing and going, and experiencing. Damon, I hear you say that you're part of like the educational board. I'd go with my mom and we talk about the importance of having Christopher Columbus stories, kind of having a different spin on them and being able to share that. And these are the memories that really stick out to me with my mom. And some of my favorite memories of my children is teaching them how to smudge and watching them walk around the house and do so around the windows, and just even leaving, cedar at your door and having it in your shoes, and the difference importance of gathering it and what you're doing it while you're gathering it, that almost like silent song that lives inside of you. So I'd say that when you're youth and I don't even know, it's so important. There's so many important factors that play into this. Having those moments of response, of smelling it, right? Like smell is so important. So to me, smudge is like going home, going to a very safe place. For me, when I hear cedar, it reminds me of being in the woods and having freedom, And I think that when we can have these little cultural moments that build up, and when we're allowed to celebrate it and to recognize who we are and transition that into adulthood, those are very important. That's very important, like having those awarenesses of transition and just being able to honor them and to appreciate them and bring an awareness, and having the awareness come into our community of like, this is who I am. And yes, you see me and I'm brown and my hair is black and it's long and it's braided or it's not. I love that, I love that awareness of being able to recognize in our community of who we are and how important it is throughout the developmental stage all the way until, way past adulthood. I'm 5 years sober, so I'm 5 years old and I'm just learning and growing constantly. And I'm just, so that's where I want to be forever, is just pour into this cup, because this cup can never be too full, you know, and to stay small and to remember those things. This is a really important discussion.
Thank you. Roger, can you sum this all up? We are getting close to the end of our session, and I hate to put people on the wire. We could go on all afternoon. So Roger, can you kind of let us know why you think we need to be vigilant with our youth on substance use?
Okay, I'll hurry along on this one, Michelle, instead of like the other ones. All right, I'm gonna go to the scientific perspective. Comes from college, you know, college classes, things like that, Prime for Life training, that kind of thing. You ever wonder why when people, like in the draft, when you get drafted into the military, or when military people are invited into the military, they have a certain time period that they're able to go in there, is between ages 18 and 26 years old. And the reason behind that is, if you're going to go into battle, you need to send somebody in that's real strong, real tough, knows that they have no limits, knows that they can't be killed. And, you know, that's 18, 19, and 20-year-olds. They've got all that power and all that energy and all that thought. But when they reach the age of 25, 26 years old, the frontal cortex starts to get wired. Well, it's pretty much all the way wired by that time. And so the thought processes are changed a whole lot. And what I've learned through the brain chemistry and things like that, is if addiction enters into the person or into the organism, on a scientific side of it there, enters into it, and addiction is taken into life prior to the frontal cortex being all the way wired, then the chances of having a life of addiction are much, much higher than after the frontal cortex is all the way wired, because then we have our higher thinking power. We can think our ways through this. You know, using this much alcohol or this much drugs or you know, meth, whatever it might be, doesn't make sense. This is not the right thing to do. And I can see that this is going to lead to a bad thing. But prior to that, the higher functions being in place, don't think of that. And then the body becomes addicted, and now there's a problem. So that's a scientific perspective on it. The big reason why we got to get it before, you know, have the addictions are not part of their lives prior to that part, so that they can think their ways through this. So I'll leave it at that. Thank you.
Thank you. This has been an amazing conversation. Everything that you guys have said have really, I think, enlightened and educated a lot of different people. One thing, because we do have a short amount of time, I want people out there to think about, when you're working with Indigenous populations, you know, wherever your treatment setting is at, maybe if you are a part of an Indigenous community, or if you're somebody who is not a part of that, but you still work within your Indigenous communities, what is it? And I don't say advice, because our best advice can get us in the crappiest places. What kind of insight would you like to have from our panelists, from their experiences? So I want to encourage you to think about that and possibly put that into a chat conversation, or, you know, we can have a conversation, an open conversation, you know, individually with each one of our panelists. Just kind of ask those questions that are going to help you to bridge those gaps when you're working with our Indigenous populations, to help support culture, to help support identity, and especially to help support the concept of harm reduction, identity of self, harmony, love, and recovery. So on that note, thank you all so much for your help and for your input and for your knowledge and your experience. Katie, back to you.
Thanks, Michelle.
Thank you so much, everyone. As a non-Indigenous person of European descent, I am just so humbled and grateful to all of you for sharing your wisdom, as you have for centuries. And we have so much to learn from you. And I'm just really grateful to all of you for being here today. I just wanted to let everyone know that next year's summit is going to be, once again, Indigenous focused. So we will have much more of this. And and I think it's going to be really amazing. So thank you so much, everybody. Let's see, got back to my script. So we are moving on. Oh, the next presentation is by yours truly, me. So we'll take just a little bit of a break here and I will be right back. Okay, here I am again. Thank you for joining me. I am Zaman. I am the Health and Wellness Program Coordinator at USU's Office of Health Equity and Community Engagement. And I'm really excited to show you a project that I've been working on. It is a project to reduce stigma of opioid use disorder and harm reduction through comics. How do I advance my screen? Okay, so today's talk is going to be really quick and I'm going to show you a video that I think you're really going to like. So we've talked a lot about stigma and how we need to reduce stigma. And I am an artist and I'm a comics artist. And I'm using comics to tell people's stories, their stories of substance use disorder and recovery and harm reduction as a way to reduce stigma. So we know that stigma is a barrier to implementation of harm reduction strategies for people with substance use disorder. So I want to hear from some of you, and I'm sorry I can't see the chat, but what are some ways that we can reduce stigma? So while you're typing some of your answers, let's just talk a little bit about how stigma is a barrier to harm reduction. So one way is that some people don't really understand what harm reduction means. And referring back to that last panel that we just saw, we need to expand our understanding of harm reduction. We need to expand how we understand these strategies. It's not just syringe exchange. It's not just medically assisted treatment. Back to what we heard from our Indigenous brothers and sisters, it is really about compassion and community and coming together to support one another. So when people hear about syringe exchange or methadone treatments, for example, they might think, isn't that enabling? We've been taught through some of these 12-step programs and other recovery programs that the only way to recover is through abstinence, but that is really only one path, and it doesn't work for everybody. So, and I'm sorry I can't see the chat, but I'm gonna give you my answer for how we can reduce stigma. So one thing we can do is treat people with substance use disorders with respect and dignity, and have compassion for them. We can use motivational interviewing to help reduce that internalized stigma, because when we're going through some of these things, society at large makes us feel like we deserve to be stigmatized, right? We use words like junkies and addicts to describe people who use substances, and that's just very harmful, both socially at large, but also for the person. We can help people think differently about this topic, right? We want to correct false information that is perpetuated through myths about substance use disorder and treatment. So things like, you know, giving people unused syringes will encourage them to use drugs. This is a myth. It's actually a harm reduction strategy that helps to keep them well through their recovery journey. And the last way that I'd like to present is that we can listen to the stories of people with substance use disorder, and that can help us develop empathy. One of the things about stigma is that we have an idea in our mind of what a person with substance use disorder looks like, or what their background is, or what their childhood was like. But that does two things. First of all, it makes it hard for people to go get help because they know they're going to be stigmatized. It also obscures the many different types of people who experience substance use disorder. And we don't think of them as someone who could have a substance use disorder, but in reality, this can happen to everybody. So my project uses the magic of comics. And when you hear the word comics, you think of comedy, you think of jokes, you might think of the Sunday Paper and Family Circus, or The Far Side, that was a great one, or Calvin and Hobbes. Some of you might think of Marvel and all the action-packed superhero stories that are really great. So this is a form of artwork that is very, very compelling. It tells stories through sequential images, simplified images with pictures and words. And this is a very, it communicates with us on a very basic human level. So as human beings, we are visual thinkers. I put this image up here of a cloud that has a shape that looks like a face. It looks like a man with a beard and big bushy hair. And it should be pretty easy for all of us to see this, because as human beings, even if you're not, even if you don't consider yourself a visual person, we all have the ability to see patterns and create ideas and understanding out of these images. We tend to look for ourselves in the world around us. We do this with astrology, and we've done this, across many different cultures and over millennia, right? So on the left, you see the constellation Orion, and someone has kindly drawn in some lines, but it's still, you can't really tell what it is. Maybe it's a headless, legless person with giving the peace sign and holding a bow and arrow. But then on the right, someone has embellished this image with more details, right? So there we see that Orion is actually maybe stomping or dancing, and he's got a big club and he's holding his fleece. And you can clearly see Orion's belt. Now we see these images and we tell stories about these images, and we see ourselves reflected in the stars. And this is a uniquely human act that we do. I was mentored by comics artist Linda Berry at UW-Madison, and this is one of her comics, and it really gives you a good idea of the power of these simplified line drawings. So you've got a mom and her baby, they're in an art museum. And she says, I'm not sure how to look at art. And he says, what's supposed to happen? Something big, a revelation. Suddenly you just understand. Wow. And she says, I'm not sure how to make it happen. And of course, children are brilliant. He says, how about lift me up so I can see better? He's going to try to help. And in that moment where she lifts him up and they look at this painting, this image, they see themselves reflected in that image. It becomes a moment of recognition and a moment of connection between them and the subjects in the painting and also the artist. So cartoons are very, very powerful. Simplified drawings can add something to a story that photographs just cannot do. So on the right here, you see two images of faces. The one image is very detailed. It has lots of shading, it has hair, it has facial features, and you recognize this as a man who is a very specific man, right? And then on the right, you see just a circle, two dots, and a line. And this image is very simplified. So we have to use our imaginations to fill in the blanks. And what happens with these simplified images is that we can see ourselves, we can see humanity, and we can see ourselves in this image. So this is an act of human connection. So getting to the project, some of my wonderful colleagues, Randy Williams, who I think is on this call, have put together a really amazing archive of stories of people who have gone through substance use disorder. And it's online. You can access this, just Google this title, and you can find 31 stories of people who are from Utah who have gone through substance use disorder. And I chose for the first story to illustrate April's story. And that's her with her 3 kids, 2 dogs, and husband there on the right. So what I'd like to do now, instead of me talking, I want to show you, well, first let me talk about the process. I got April's permission, of course, to illustrate her story. I listened to her story over and over. I created a storyboard, and then I got it approved by her. And she was very involved in the process of, making sure that I got everything right. She helped me with the timeline. She helped me with some of the details. And then I created this comic. So what I'm going to do is show you this wonderful video that my colleague Jameen Fitzgerald has put together. And what she did was she spliced the audio from April's interview onto my drawings. So what you're going to hear next is April's voice telling her story with my illustrations. So 1 second, let me make sure. Share sound. All right. Can everyone see that? And obviously I can't see you. All right, here we go.
We have a huge family, so there's 9 girls and 1 boy, plus 3 siblings that are all adopted siblings. I grew up with loving and supportive parents. They're just great and wonderful. My dad was a really hard worker. He always had 2 to 3 jobs. My dad is a professor and for computers, and then he is also, what else? He has his own business finding guys, people like that flee the country and stuff. And so my dad was always out of the country a lot, which was kind of crazy growing up. I always knew I wanted to teach, be a school teacher, because my 2nd grade teacher was amazing. My 1st grade teacher was horrible. So my 2nd grade teacher was absolutely amazing. And so I knew I wanted to be a teacher. So basically, I always had a job pretty much since I was about 15, 16, babysat. I started kind of tutoring kids on the side, which was really nice. Tutored them in reading. And then I moved to Alaska right when I graduated, and I worked in a fishing cannery, which was really crazy work. It was like 20-hour days. It was pretty intense, 7 days a week in Ketchikan, Alaska, at Ward's Cove Packing Company. I did that with my sister Aubrey and my best friend at the time. and we went out there, and it was my sister's second season, my first season. So went out there and did that. After that, we met some really good friends. I started playing a lot of guitar from friends that were in the cannery, and a lot of them lived in Oregon. So I moved to Oregon. And when I lived in Portland, Oregon area, and then I went to school at Western Oregon University. And I was working there at the physical plant. And at the physical plant, it was on campus of the university. And it's a really good teaching school, one of the best in Oregon. So while I was in school, in college, I was at the physical plant, and I would do anything for like any repairs that would happen that I'd have to do, painting, just like small home repairs that I'd have to do on the campus, like patching up holes, stuff like that. And it was a lot of fun. So I got cut on my hand, like right here, on my finger, my pointer finger on my left hand. It's barely visible. And that's what did it. That's when the beast came. And so I cut myself at the physical plant when I was painting or prepping for a room. And I sliced myself with a razor. Anyway, so I was supposed to be at class that day, and they made me go, and they were like, you need to go in, workers' comp issues. And so I went in. I was probably 19 years old. Was 19? Yeah, 19. So I was 19 years old, and I went in, and my doctor, it didn't even really hurt that badly, but I did exactly what he said. He prescribed me a big bottle of Lortab and said, here, take this. I'm like, okay, and it's a tiny little cut. I'm like, all right. So I remember going home and feeling kind of lonely and sad because I was away from my family for the first time for a long time, going to college. And I remember taking it for my finger, and I remember it just made me sleep. It made me sleep a whole bunch. I was so tired, and I was like, oh, wow, this is cool. This is helping me sleep, and my finger doesn't hurt. Not like it really hurt before, but anyway. So I took that bottle, but that was my first experience. I was like, hey, this is kind of making the sadness of being away from my family kind of gone. So that was my first experience. Started school at UNLV, and I was working in the school district out there, and I was kind of like an aide / sub, and I worked with kids with special needs. I worked on Marie Callender's for a little bit in Las Vegas. It was like 4 times the amount of money than tutoring is, because it just is way better pay. I did that for a while, and then I missed my kids. I missed working with kids, so I went back again and did worked with kids with autism and worked in the school district. I want to say 23. That's when I got the official diagnosis for endometriosis, severe endometriosis. About, let's see, 6 to 7 years ago is when it was like, I would call it a binge. I had got those pills when I went to my doctor, because Jason and I were looking into having a baby, and I went in, and I was having horrific painful periods. It was just like debilitating, to where I would lay on the ground and just be shaking. And I went through my doctor, and I went through a local doctor out here. And she was nervous because I had to go to her a few times to get, and I think I got like Lortab one time, and then one time I got like codeine another time. I didn't really have a preference when it came to those drugs, as long as it was like an opioid that did, I know I can't stop fidgeting with stuff. As long as it was an opioid that did the trick. I didn't like muscle relaxers. I didn't like anything. I would say most like Lortab, Oxycontin, codeine, those things. And so so I went to a doctor out here, and then it was so severe. I had one doctor though that made a difference. He intervened, and he actually said, and I was still in denial that I had a problem, and he said, I went and saw him, and he was like, he filled in for my regular doctor that day, and he was like, I looked up your information on there. It looks like you come in every month to get stuff for your period. And he's like, this needs to stop. At the time I was angry, like, are you saying I have a problem? This is ridiculous. And I just remember going off on him, kind of like, that's not okay, blah, 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 blah. And then looking back now in hindsight, I was like, wow, that was the only doctor that actually gave a crap, that actually like really made me, kind of put me in check. I remember him calling me later that day, and he was like, he must have talked to somebody. He's like, I'm sorry that I made you feel that way or whatever. And he's like, if you have issues, please let me know. And that was the one doctor that did that. And I think that they needed, I don't know, like, obviously if you're going to a pain specialist and you're getting tons and tons of stuff, like, there's an issue there. I mean, it was definitely my fault, and I shouldn't have, like, I shouldn't have had access to all of that. I had so many pills. I was given so many pills, and a lot of them I didn't take because I wasn't like really into the muscle relaxers. I mean, I just wanted the straight opioids. So, you know, doctors need to be aware. Then the next meeting I had with my doctor, again, she said, okay, you need to, I can't do this anymore because your endometriosis is too severe. You need to go to a pain specialist. And then I was referred to Utah pain specialists in, I don't know exactly where it was located, but so I went there, and that's when it just went downhill from there for a couple years. I was trying to have a baby with my first husband, and that's when I found out. Where I was at, it was either I had to have a hysterectomy, which meant no kids at all, or I could keep trying. And so for me, I felt like I was between a rock and a hard place. Like there was no alternatives. It was either I was in serious amounts of pain or I couldn't have kids. And for me, it was just like absolutely like, it was a horrible place to be. I didn't feel like I had any alternatives, you know? And that's what got me to, you know, where I was at. Like, and the doctor would, you know, I feel like if my doctors would have pushed me to do something else, but the pain specialist was like, what do you want? What can I give you? What's going to help your pain go away? For me, more than anything, was the knowing that I couldn't have kids. Like that was just very painful, and it still is, you know. And, you know, that like just like being raised, I mean, any religion, just being a woman in general, like that's your right to have a child. And then all of a sudden realizing, oh, wait, I can't. Oh, they prescribed me everything and anything I wanted, which was, so they had me on muscle relaxers. They had me on Tramadol. They had me on, I was on so many things. They had me on Oxycontin. There were just tons of things that she had me on. And I felt like in my mind it was okay because I was taking medicine that this doctor had prescribed me. So I was like, oh, this is okay. I remember at one point, like, looking in my cupboard, I was like, holy moly, it was just full of like prescriptions. And it was all from the same doctor, all from the same pain specialist. I was like, wow. Look at all these pretty pill bottles. We went through foster to adopt. We adopted our first child, and then we had him for a long time, for about a year. We fought for him for about 2 years through the system. And I think I just kind of snapped because then they took him away and kept giving him back to the mom. And it was finally, it was just so emotional that I just like, and then I started all of a sudden masking my feelings with opioids. And then I was like, wow, I'm taking this as directed, but then I'm taking a little bit more because I'm sad, and it would totally mask those feelings, you know, temporarily mask. They put me on this patch of some kind. I went to Cedar City to go see the family, and my family was like, oh my gosh, April, you're out of it. And I was totally out of it. And they had talked to my husband, Jason, so I came back from Cedar City, and then they all confronted me. All my friends know what happened. And some of them were ones that pointed it out to me. They're like, April, what the heck? Like, what is your deal? It was great. It was like an intervention. I was like, oh my heck, I have an issue here. And so my husband told me, he's like, you need to get off of this stuff. Like, I don't care if, you know, we don't need to keep trying to have a baby. We don't need to keep, you know, you need to get off of everything. And then when we finally got him back and we knew we were going to keep him forever, that, you know, I was like, oh crap. And I remember trying to stop taking pills. And I remember stopped taking them and I started getting sick. And I was like, oh my heck, this is what I've seen like in movies and Lifetime TV. And I went to LDS hospital and I did, I was there for about a week, and they put me on Suboxone. I was on Suboxone for about almost 2.5 years. Suboxone, had to use it every day. And it was a lifesaver. It was a lifesaver because I know there's a lot of like skepticism around it and things. For me, it was good because I tapered down to such a low milligram. My feeling about Suboxone is 100% has to be highly monitored. So I went to NA for, I want to say, a few months, maybe 6 months or so. I can't remember exactly. And that was really, really helpful. So I did that. I loved it. And then my husband had me go to these behavioral mental health classes, and I did not really enjoy that at all. And I wasn't mandated to go. So when I would go to the behavior classes, I felt like, oh, here I am, like this teacher, like all dressed up like, hi. And there's like a bunch of people in there that were like very much like, I don't want to be here. I think about people that slip, or, you know, and it happens all the time where they, you know, start using again. But I know that's not even an option for me, because not like I'm better or stronger or whatever than those people, but I know I'll lose everything, and I can't lose everything. I know everything will be gone. And I can't have that. I can't lose my family. It's been 3.5 years now and 0 relapses with opioids. 0 relapses. I'm so proud of myself. Every day is a struggle. Absolutely. Just keeping strong every day. Just life, life gets hard. You have to find other ways to self-soothe, I guess. Spending time with my kids is actually very self-soothing. You have to be active and involved in your community. I do a lot of charitable work, just going out and being outside. We're very much outdoors, an outdoorsy family, and so that is very therapeutic. At first, when I was at LDS Hospital, they put me in a really high dose to compete with. They didn't want me to have I did have withdrawals, but they weren't as significant. And that was one thing that kept me, I think, using at one point, was that those withdrawals were so horrific. I mean, it felt like you have the flu and you're just so completely sick and you can't even move, but you have to keep continuing life. So you get back on it just so you can function. That tiny little mark, and that's a reminder. And I'm glad I still have that on my hand, on my finger, my pointer finger. It's like a tiny little scar in the middle of my finger. And sometimes I'll look at it and I'm just like, wow. I consider myself one of the lucky ones. There's no reason a 19-year-old girl should have gotten a huge bottle of pills for a tiny little cut. I think people need to have a lot of empathy for people that go through this. And I think there needs to be more of awareness. What I think there needs to be more of awareness that it can happen to anybody. I need to get more involved. I think I'm just too scared. I'm too scared because of the stigma. I don't want somebody looking at me saying, there's so-and-so, she's an addict. Yeah, I'm an addict, but you don't really know my story. I had a great normal childhood. Really good sisters, a really good brother. I had a normal, healthy life. We were financially very well off. And it's too easily accessible, and it's sad. Find a support group. NA is by far where you will not feel alone. There's hope out there.
All right. Thank you so much, everybody. We are getting close to time, but if anyone has any questions, please let me know. I'm looking at your chats. Thank you for posting the link, Claire, to the narrative. There are so many wonderful stories in there. And if you were in this morning session, you heard many, many shout outs to Savannah. And I'm currently working on her story. So I'm so excited to be working with these wonderful community scholars who are open and vulnerable and sharing their stories, and we'll get these out to a broader audience. So we're gonna publish 2 compiled graphic novels, each with different stories of opioid use disorder and recovery. And yeah, please get in touch if you have questions. I love to talk about it. If you wanna draw with me, I am always available. And let's see, now I have to get back to my MC duties. So, all right, it's lunchtime. During the next hour, we hope you'll enjoy one of 3 fun activities. Don't forget to do the goose chase. There are prizes. There's prizes. We also have Donnie Arnold again doing the Healing Trauma Art Workshop, and then Simple Start with My Plate, Rainbow Wrap Lunches. I want one of those. Presented by Kara Murray. Or you can take a walk and work on your goose chase, scavenger hunt. Someone will put the links to those sessions in the chat box. Our afternoon breakout sessions begin at 1 p.m. and links to those breakout sessions are in your summit agenda. And we'll also put those in the chat box as well. So I will see you all shortly. Thank you so much.
Hi, everybody. Just a quick reminder that our lunchtime sessions have started. So if you would like to check those out, please do. Our first round of breakout sessions this afternoon will start at 1 o'clock, and we will put the links to that in the chat box in about half an hour. If you need one right now, feel free to let me know and we can put them in now. They will also be in your reminder emails. During the break, this webinar room will be open in case of questions or concerns. We will also be sharing some artwork from some amazing artists who participate in the Addict to Artist program. If you are unfamiliar with this program, it is a recovery-based, all-inclusive program that supports any and all affected by addiction. They strive to create a safe and supportive group where those affected by addiction can express their feelings and experiences through art. The philosophy is to erase the destructive influences of addiction and replace them with a positive and meaningful experience, while creating a safe community to share, support, and learn about art as well as addiction, and turn the mess into a message. Addict to Artist is a free community support group that uses art to assist in achieving long-term sobriety and personal recovery. As an artist, participants are creators, and Addict to Artist allows them the platform to turn addiction's destruction into sobriety success through the erase and replace philosophy. Erase addiction and replacing it with something of greater value. Addict to Artist finds purpose in art. They aim to erase the perception of the word addict in the public eye and in the minds of the sufferers themselves. They are a support group available to anyone touched by addiction, whether in recovery personally or those with family or friends who have or are currently battling addiction. So if you choose to remain in this session, please enjoy this beautiful artwork. And if not, we hope to see you in one of our other lunchtime sessions. Thank you.